will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our Education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The step-by-step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy. will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The step-by-step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy. will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The step-by-step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy. will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The Step-by-Step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy.
그래서 나랑 자리 바꾼다 그랬잖아. Good morning, everyone, ladies and gentlemen, and my colleague and friend from around the world. I'm delighted to welcome you to the 14th edition of this didactic course, an event that has become a cornerstone in the world of spinal education. I'm Dr. Gun Choi, and I'm truly honored to be your host for this exceptional conference. Today, we will embark on a journey that will not only broaden our horizon, but also transform the way we perceive and practice endoscopic spine surgery. Especially in this 14th edition of Didactic course, we are focusing our attention on a subject that has seen increasing growth and interest in the field of spinal surgery, unilateral bipolar endoscopy, or UB for short. Throughout this conference, you will have the privilege of learning from our world-leading expert in the field. They will share insight, experience, and groundbreaking innovation through a number of lecture and live surgery. We will deliver today valuable knowledge in UV from basic technique and the concept to the most advanced one, giving you a comprehensive understanding of its power and potential. I encourage you all to actively participate, ask questions, and engage with our team of experts. Let's make this conference not just the event on your calendar, but a turning point in your spine journey. Thank you for being a part of this remarkable event, and enjoy the course. Thank you very much.
Good morning to our audience joining us today online in the 14th installment of the Didactic course, this time with special focus on unilateral biportal endoscopic spine surgery. My name is Michael, and I will be your host for the course of this day. We welcome those of you that have logged on and hope that all our viewers are looking forward to the discussions and live surgeries as much as I am. It will be a happy occasion for all members to participate and enjoy. With the effort of the legendary Dr. Gun Choi, we gathered some of the world's most brilliant UBE surgeons to share some of their knowledge and skills. UBE has seen continuous local growth here in Korea and in Asia in the past years, and we wish to show you today some of the advancements and uses of the biportal technique. We hold a strong conviction that to move the realm of endoscopic spine surgery to new heights, spine surgeons must possess a deep understanding of the most updated principles of our field. With that being said, let's begin this Saturday with a couple of our lectures followed by 2 live surgeries. We'll begin the Saturday course with some of our lectures. It is my honor to introduce our first speaker, Dr. Alfonso Garcia. Dr. Alfonso Garcia is one of the leading endoscopic spine surgeons in Mexico, working in Espalda Saludable in Tijuana. Dr. Garcia So Dr. Garcia has contributed to the advancement of endoscopic spine field, not only in Mexico, but in all Latin America, having active participations in global meetings, collaborated as writer for several chapters in major endoscopic spine textbooks.
And please let me know.
He'll join us today to give us more information on the emergence of UBE. Thank you for being with us today, Dr. Alfonso. Can you hear me? Yeah, okay.
Yes, everything good?
Yes, everything good. It's a pleasure to have you today, Dr. Alfonso.
Okay, thank you. Thank you. So I should start right away?
Please, you have the word.
Okay, thank you. Thank you for having me. I'm so honored to be here. And Pohang is like my second home. I miss Pohang a lot. Dr. Gunchoy, thank you very much for inviting me. And let's start. So the title of my talk is Meet the New. Though biportal endoscopic surgery is not that new, it has recently developed a very important surge in the last, I would say, 5 years or so. The interests are many, and we will try and show you why, on my personal behalf, this interest has become more available. So endoscopic spine surgery is not just a technique. It's actually a platform that facilitates optimal visualization and maximum conservation of healthy tissue. So with that in mind, I would like to review a little bit of how unilateral biportal endoscopic surgery developed in this very brief timeline. Actually, both full endoscopic spine surgery approaches came from the same background. We developed endoscopic surgery through percutaneous approaches. So before we put the scope in, we used to put instruments with just the aid of X-ray machine. So in the early 90s and late 80s, Dr. Kambin, obviously we all know how he developed and found this safety corridor that we now know as the Kambin's triangle, that usually now it's a reference. We use bony structures as landing points, but Kambin triangle is a very important structure because it aid in developing the first scopes. So that's where percutaneous shift to letting the eye of the surgeon go into the surgical field. So as you can see by the yellow-orange shadow there, there's an arm that is growth and separated in parallel with uniportal techniques, which developed in the mid-1990s, believe it or not, in Latin America, in Argentina, with Dr. D'Antoni. He is the first who published the unilateral biportal endoscopic approach. And then afterward, the technique was further developed by Dr. Ghaffar Abdul and one of my mentors, Dr. Om-Jin Hua. So from there on, about 2003, early 2000s, up to now, both full endoscopic spine approaches have developed in parallel. As you can see, up to 2023, and UBE still continues to grow, but in parallel. So the ultimate goal of any full endoscopic spine surgery is to obtain minimal disruption of healthy tissue, expanded angle view of a field of view, and be efficient in correcting pathology. So with that in mind, there's only really two full endoscopic spine surgery techniques. There's the uniportal, which enables the typoscope to have a working channel, so we can use it to put instruments in, and the biportal technique, which gives the surgeon a little bit more of ease and freedom of movement of both hands. And so in biportal, the main characteristic is that one portal is used for the scope and the other portal is used as a working channel. So one of the main advantages, as I mentioned before, is the freedom of movement. So as a surgeon, you don't feel limited by the working channel of a uniportal scope. And this is because the optics is separated from the working channel. So it gives you a better view due to the larger size lens. So it also has the advantage that has a larger working channel, so you can put regular neurosurgical instruments as you would use in any spine or open spine surgery. And it's also very familiar to the surgeon, to the spine surgeon, because it mimics very similar to open surgery. So the main indications or the advantage that differentiates from uniportal, it aids to better and to improve fusion technique, stenosis cases, also with multiple level pathology and multi-level surgery when we need to approach more than two adjacent levels. Biportal comes in handy. Even though you need two incisions, you can share one of the incisions when you go up or down. So in this comprehensive review, the recommendations for either uniportal or biportal is as follows. I'm sorry, depending on where the pathology is, either central, lateral recess, foraminal, or extraforaminal, we have different approaches. So for central and lateral recess, we can share both the interlaminar approach. And also the transforaminal approach can be aided for foraminal pathology and obviously extraforaminal pathology. So biportal surgery, it's a type of interlaminar approach. So it would be very helpful in central spinal pathology and also a little bit of lateral recess. And we're going to get into the foraminal and extraforaminal in another slide that I would like to talk about it. So biportal is a type of interlaminar approach. It does not replace uniportal. It's just another tool to utilize. It is appropriate for a broad indications with its own benefits and challenges. It's also very beneficial for centrally located pathology, including stenosis and fusion cases, and not the ideal approach for extraforaminal herniations, foraminal stenosis, thoracic cases, cervical cases, compared to uniportal approaches. This is, I mean, I don't mean to say it's not indicated, it's just not ideal. It can be done, and many surgeons do it for cervical, thoracic cases, and also extraforaminal, because you can approach with a far lateral approach. But that's another chapter for more advanced cases. Very early on, when I was in Korea during my training, I realized there's a huge difference in the type of patients we see in America and that we see in Asia. For instance, in South Korea, by this update, which is not very recent, but until 2017, the obesity rate in South Korea is just 5%, compared to almost 33% of obese patients in Mexico. So as you can see, the type of patient we have at the OR are very different than the type of patients I learned on and I used to aid in operating in Korea. So putting that in hand, this is one of my first cases I operated with biportal endoscopic surgery. It's a 23-year-old young man. I had to do a rehearsal first and do level marking because he was a very big patient, a little bit over 400 pounds. That means around 220 kilograms. So he was a very problem patient because of his size. But even though the size was a problem, we didn't have any problem there. Longer instruments through an interlaminar approach to treat a congenital stenosis case, a 2-level congenital stenosis case, and the patient came out very good after that surgery. So how it's done, one side approach, two portals. Obviously, I will repeat, one portal is used very similar to arthroscopic surgery. So one is for the scope, the other is for specialized instruments. And even though it's two portals that are used, it is still a one-handed surgery. Why? Because the surgeon is able to use only one hand for instruments, even though with the other hand, he is holding the scope. That scope is not for work, it's just for optics. So believe it or not, this was my instrument set. Only 3 instruments. We had a double dissector, we had a muscle elevator, and we have a very important nerve retractor. So that was it. That was what we had back then. And we had a basic 4mm scope. We used to put in the 0-degree scope, the 20-degree, and the 70-degree scope. We had a diamond and cutting burrs, and we obviously had different kinds of RF probes. This side contact RF probe, which is a little bit large in size, is very handy for the initial dissection. But now, I mean, this is part of what's new with this new player. We have more drills, we have more availability, we have a variety of RF probes to fit into every corner. We have changes in the cannula design for the scope, and obviously we incorporated rotating kerosene. Rotating kerosene come in very handy because sometimes you end up touching your scope. So in order to be more efficient, the tip of the kerosene, it's able to rotate 360 degrees. So that is very important tool to have in handy. So this is how it looks. This is the workflow. This is a fully draped patient. And it works like something like this. So the first axis is the lever marking, the incision, the sequential dilation, the insertion of the high flow shaft with obturator and the scope. Second axis for a triangulation tool follows the guiding rod, guiding tubes, working tube, and then what you need to put in, which is the instrument. And I like very much the flow that the image here that you see from the X-ray. So the scope for a right-handed surgeon from a left side approach would be at the far lower end of the pedicle. That is what you would use for incision for the scope. And for your instrument or working channel, you would use the medial pedicular line where it intersects with the upper ridge of the lower lamina. That is a very basic construction, and both instruments should meet in the center, like very much in this picture. So axis options, left side pathology, it's easier for a right-hand surgeon, instruments on the right hand. And right side pathology, I will show you some diagrams following, but you can adjust the axis angles more caudally to reach under the lamina. And also you can approach from the contralateral side. That means that the surgeon can be standing on the left and approach on the right side. So, and sometimes some surgeons can do it. I can't. They switch hands. I cannot do it. So this is one of the diagrams you'll probably find more handy. So let's see a left surgeon on the left, head is here, feet are here. So this is a very basic left side approach. 1, 2 incisions, one for the scope, one for the instruments, about 2 centimeters apart. This is the other variant I talked about. Surgeon is still on the left, head towards this side, feet towards this side, but the surgeon approaches directly on the right side. That's not a problem. Very easy to do. And the other challenge is because you have to move in just a bit caudal to get right, because remember, this is the working channel and this would be the scope, unless you are one of those surgeons that can chance with put scope here and the instrument here. But I find that very. How does it go? We put the serial dilators through the inlets, and we have to be very careful of this. And I remember what Dr. Guncho used to tell me on how to avoid what is the best way to control bleeding. It's actually to avoid it. And you have to be very aware of where the arteries are. So we see this green circle right here. This is all safe spots. We don't have that much circulation, that arterial bleeding going on there. So when you start detaching muscle, just keep very close to the lamina. And once you keep close to the lamina and what you put your scope in and you see your other instrument to create your first triangulation, it would be a very clean field of view. So you won't have any problems. So the next step is to do muscle detaching. This instrument looks very big, but it's actually very delicate because it is very easy to control with your hand. So it's almost like the tip of your finger that you can feel very well with this blunt tip, and you can use it to contour the upper part of the lamina, the lower part of the upper lamina, and then detach that fine muscle attachments to that bone so you can create first space. And then comes in putting the instruments. So remember, a right-handed surgeon will hold his instruments with the right and the scope with the left, like it looks in the picture. And now, as I told you, we have this very interesting cannulas that have very small cuttings there to direct the water flow, and that actually helps in the dissection. So it keeps the view of field very clear, and it is very easy to identify. So this is what we're looking, and we're going to see a couple of examples and clinical cases and see how everything comes together. So we keep a normal saline flow between 30 and 40 millimeters of mercury. Usually water arthroscopy water pump. You can use gravity, but I feel more at ease with a water pump. And it's the same steps. Do the bone work first, leave the ligamentum flavum second, so you can identify the lamina here, the flavum already all dissected. So let's go ahead and see an example. So this is an L4-5 spinal stenosis of grade 1, stable spondylolisthesis, a very straightforward case. So we're going to do a contralateral sublaminoplasty. So it's a bilateral decompression, which we're going to start a right side approach at L4-5. This is the pre-op MRI. You see it's a very straightforward, basic stenosis case, very familiar with the pathology, with the images. And this is the CT scan. Also, that you can see that most of the pathology is onto the contralateral left side. So this is the basic level definition. The dilators coming in with the muscle detachment tool. So this is basically what we're going to do. We're going to do an ipsilateral decompression and then go over the top and do a bilateral decompression. And the video as follows. On the lower part of the screen, you see the images for a uniportal approach, but it's basically the same. As you can see, before the rongers came in, I used a Correct. You see the side contact RF probe. Most of the ipsilateral decompression is already done, and we're going to follow through the midline and go to the contralateral side. We see some of the flavum up there. We use the RF probe, some of the kerosene to remove the excess and thick ligamentum flavum. And as you can see, I'm using a cutting burr with a protection sleeve right here at the bottom, which is very important. And I can go very to the other side. See all this space that here. This is the dura visible. So it gives the surgeon a very clear image of what he's doing, and that avoids accidental damage of healthy tissue. So this is the post-op decompression. As you can see, there's very little or none muscle edema. You can't distinguish any incision there. The level is fully decompressed on the axial view. The fully restored and fully decompressed thecal sac right there with a small tube for drainage. And we're going to jump over to another more advanced technique, which is the cervical unilateral biportal endoscopic decompression. And the cases of a 39-year-old young male with chronic cervical pain and left side shoulder pain, 1 week of acute severe pain with a scale of 10 to 10 that radiates to left arm, unresponsive, no pain relief with meds and therapy. So on physical exam, we have hypoesthesia on left C7, left elbow extension 405, and DTR, deep and then reflexes are not specific. So this is the MRI. The pathology is also very straightforward and very. The idea is to do a small laminotomy to remove that disc. So the problem list is a left C7 radiculopathy with a posterolateral herniated disc at C6, C7 level. So the surgical plan is the biportal endoscopic cervical decompression with a C6 and 7 left lamina foraminotomy with disc fragmentectomy. The difference between the cervical and the lumbar spine is at the cervical, we do have to be a little bit more precise. Even though it is safe to introduce the instruments, I like to use a needle placement first on the AP to just identify the space and double check in the lateral view that we're okay. And we do same incision and start the dissection just exactly as we did with the lumbar spine. And we do the triangulation last with the introduction of the scope, and they meet with the dissector to do the triangulation of the instruments. So this is the image and the orientation we will be looking at. We will be working right here at that intersection. And this is the video from the surgery. We got medial, lateral, caudal, and cephalad, as you can see. So it's a very similar surgery to what we do with a mini open lamina foraminotomy. In this case, we have constantly water flow, cleaning our field of view, and we can easily use the Kerrison to keep it safe. More advanced and more experienced surgeon use the diamond burr all of the time, which I find it more safe now than when I used to do my first cases, because you don't put any pressure on the thecal sac. And obviously, we all know that in the cervical segment, the spine is very itchy about having that extra pressure. So we are coagulating and using that RF Pro to clean our view. And as you can see now, we have a very clean and straightforward approach. We use that curette to elevate the flavum, and we managed to reach and put the hockey stick and to start remove that needed. As you can see, the neural elements are very rarely manipulated, so it is very safe to use that hook to remove the disc. You can tell one of there are many things to criticize. I open a bit more own. I was able to manage this case without any problems. So this is the exiting nerve root right here, and we're looking to see if there's more fragments. I think there's a little bit, yeah. We're going to remove some more disc from there. you can see the zoom advantage that we see and the clarity with the extra scope that we have there. It is way better because obviously the diameter lens, it is very important. So more light can come through in, and more light means more clear image and more defined image. One thing that I love about endoscopic surgery for unipolar and bilateral is documentation. You cannot argue how well document surgery, and obviously it helps a lot with personal growth. If you can see your videos, if you can auto criticize your work to improve as you follow with more and end result, fully decompress segment the small incisions, the disc fragments that we took out. So what we can do ipsilateral posterior approaches. We can do contralateral approach. As I told you earlier, we can do far lateral paraspinal, mimicking the Wiltse approach. Obviously, it's a little bit more advanced cases because the anatomy through small incisions, it's a little difficult. At least I found it difficult when I was learning, and definitely very handy in fusion cases. So these are my references. And thank you very much. I think it was a little bit short of the time expected. And please do share your thoughts. This is my social media from Facebook, Instagram, my webpage, and my email, info@espaldasaludable.mx, which means healthy spine. Thank you very much.
Thank you very much for your wonderful lecture. I actually have some questions for myself. I myself am from Brazil.
Yes.
I would like to ask some questions to you. How is the current state of the adoption of biportal technique in Mexico? How do you feel the adoption is right now?
It is very fast. A lot of surgeons who go to those weekend workshops want to get right away and start working. I think we share something between Latin America countries is that we are still countries in development. Technology available, such as we have in South Korea and other Asian, more developed countries, medically speaking, about technology like we do have in the US. So biportal technique is a very friendly technique because you can actually make your instruments out of an ordinary arthroscopy set. So you just need a little bit of creativity, and you can use the regular instruments you use for spine surgery, and you can start right away. So you actually don't need those upgraded instrument sets that we now have available, which I didn't have when I was learning that technique. So I think that makes it for a very friendly and approachable technique. And I think that's why many countries in Latin America.
If you allow me, I'll make a second question. What do you believe are the challenges we'll face for the biportal technique to groundbreak in Latin America and in Mexico?
Oh, definitely. I think teaching is very important. One of the challenges and problems we are now facing is we are seeing a lot of complications because surgeons think that it is very easy, and with just attending a short weekend course and maybe seeing one or two cases, they can go right ahead and do the technique, and it doesn't happen that way. So we have to be very aware and in both not to lose the enthusiasm that new surgeons want to keep to that they need a very specialized and specific training.
Thank you very much for your time and for your wonderful lecture. It's a pleasure to have you today again.
Thank you. Thank you.
Now, for our next presentation, it is a great pleasure to introduce our next expert, Dr. Jo Leung Pao, for short, Dr. Pao, from the Far Eastern Memorial Hospital in Taiwan. Dr. Pao is one of the leading unilateral biportal endoscopic spine surgeons, having contributed to the advancement of the technique in Taiwan and in Asia through a series of scientific paperworks, international lectures, and textbook contributions. I thank for your presence, and we will begin shortly with the lecture of Dr. Pao.
Okay, is the video okay? Are we online? Okay, thank you. Nice to meet you. Thank you for your inviting me to this wonderful conference. I have been here for 7 years ago in 2017. At that time, it is winter time, very freaking cold. Now, today it is warm. Okay, today I'm going to share you with my experience in how to avoid the dural tear in the UBE surgery. I will introduce you the no punch decompression and safe drilling technique. That is the photos that I visited Pohang in 2017, the sixth didactic course of endoscopic spine surgery. That is the first time I met UBE, and I learned the concept of UBE. And then after I returned to Taipei, I started to start my UBE surgery since 2018. The UBE is a very good surgical technique that we can perform the surgery in a magnified crystal clear surgical field. It is almost bloodless, and we can work through small surgical wound, but inside there is a very big working space that we can perform almost every kind of spine surgery under the endoscope with very clear view. So, because the UBE technique is so wonderful that we always look on the bright side of the surgery, and we tend to neglect the dark side of the surgery. But every surgery does have complications, and as with that is also true for the UBE surgery. We have the complication rate about 7%, no matter how experienced you are. And the dural tear is the most common complications in the UBE surgery.
Just one moment, Dr. May
Yes.
I interrupt? We're just having a little bit of problems with
Yeah?
the slideshows. That's not appearing the new slides that you are showing.
Wow.
Just 1 second.
Mm-hmm.
about.
So it's just to come back to the previous slide, that the complication of UB surgery is about 7%, no matter how experienced you are. And the dural tear is the most common complication for the UB surgery. So to err is human, but we all, when we have the dural tear, we all say that is a complication that will occur. But I think the complication can be avoided actually. So how many more errors are you going to repeat? We need to refine our technique to avoid such kind of complications. Of course, there are many ways to repair the dural tear. You can use the patch compression method that was reported by the Dr. Choi, Daizhong Choi. And also you can use the endoscopic clipping sutures that may not be available in every hospital, but it is a fancy technique to repair the dural tears. But also you can use the suture technique to repair the dural tear directly under the endoscope. It is doable. It is doable, and it is you can do it. You can do that. It will take about 20 minutes for 2 stages. But the best way of is to prevent the dural tear in advance before you do this, have these complications. And before you do, you know how to avoid the complication. You need to know where the danger is. Before we use the endoscope, we tend to neglect it that there is always a severe adhesion and inflammation underneath the ligamentum flavum. But now we have the endoscope, we can see it very clearly under the endoscope. So we now re-evaluate the condition that there is always severe inflammation and adhesion under the ligamentum flavum, especially in the cases of severe stenosis. And when you elevate the ligamentum flavum, you will see a very inflamed dura that we may call it angry dura. So if you there is also a unique feature in the endoscope that is called central fold. It is because of the water pressure pressed down the dura and let the central fold become more prominent. And also there is a structure called the epidural ligament. If you neglect this structure, you may have the dural tear, but you did not notice because some of these structures was obstructed by the epidural fat or the ligamentum flavum that was not removed. Yeah. So you need to take some cautions about these structures. And every kind of instrument that we use in the UB surgery will cause dural tear. And in our experience, the calcium rupture is the most offending instrument to cause the dural tear. So we decided not to use the calcium rupture anymore. Instead we use the high-speed burr and the osteotome to do the decompression procedures. The most important instrument is the burr. We use the electric burr, and that is a thin and a long shaft because it is a thin that the outflow is smooth through the small surgical wound. And we use the coils diamond burr because it is efficient and safe. And the machine should have adjustable RPM. The burr should be lightweighted, and it should have the reversible drilling mode. And it is better to have a programmable foot pedal control. I will show you why. There are so many drill tips for the drilling systems. We have a 5-diamond burr, coils diamond burr. We have also the cutting burr. But I recommended to use the round shape of the coils diamond burr because it is efficient and safe. It is safer than the cutting burr. It is more efficient than the 5-diamond burr. And that is comparison between the cutting burr and the diamond burr. With the diamond burr, it is a two-way operation. Either way, you can use forward drilling or backward drilling. It is equally effective. But for the cutting burr, you can only use the forward drill. The backward drill is of no effect. So there's some of the technique for using the burr. We can use the tip. We can use the side of the burr. We can also use the withdraw drill or the backward drill. I think the most efficient is the side drill. And the most safe technique is the withdraw technique, withdraw or backward drilling technique, because you determine the depths first, and you use the backward drill to remove the bone, and you will have no push downward pressure that your burr will not intrude it in the epidural space. And then we talk about the machine. I like to use the machine with adjustable RPM. And the most frequent RPM that I use is 25,000 to 30,000 RPM, and that is enough. That is enough. Although the machine may provide 80,000 or 90,000 RPM per minute, but I think it is too much, because the higher RPM you will make your blur your surgical field. And I think the forward drill mode and the backward drill mode is also very important. I will tell you why. And you can have a setting up the program, your foot control pedal to switch the backward and the forward drill mode. Why the reversibility is that important? That before we use the drill, we should separate the ligamentum flavum from detach the ligamentum flavum from the undersurface of the lamina before we insert the drill inside that space. In this illustration, you see that when you use the reverse mode in the contralateral approach from right side, if we use the reverse drilling mode, it is safe because you will press down the ligamentum flavum and use the ligamentum flavum as a protector for the dura. But if you use the forward drilling mode, it will flare up the ligamentum flavum and make the drill intruded into the epidural space. I show you in that is the intraoperative video. You can see the left side is that case is a contralateral approach from right side, and the left video is reverse mode. You see the ligamentum flavum was pressed down by the drill, and it is safe. There is no chance to get injured to the dura. But on the right side of the video, if we use the forward drill, the ligamentum flavum will be flare up, and the drill will intrude it into the epidural space. So, and this is another example for the backward and the forward drill. For the cervical spine, after the ligamentum flavum was detached, if you use the forward drill, the drill will jump into the epidural space. That is very dangerous for the spinal cord. Yeah, in this video demo, you can see clearly why the burr will intrude it into the epidural space. But when we switch to the reverse mode, there will be no chance for the drill bit to get into the epidural space. So you check the machine. You should have the machine with the reverse mode. Okay. And the control of the burr is very important. When you hold the burr, you should not hold the burr very tight. Just like you practice the Chinese calligraphy, the pen or the burr is just holding in your hand. You not grab it. You should not grab it very tight, that you can control in a very relaxed posture. And you should practice day by day to refine your surgical technique. The best technique is to remove the lamina, to leave the lamina a very thin layer of lamina. That technique is very suitable for when you perform the thoracic spine in a surgery for thoracic spine or cervical spine. If you want to decompress the spinal cord, then when you remove the lamina, leaving the lamina a very thin layer, then you can use the curette or use the nerve hook to elevate the lamina. Then you don't need to use the Harrison punch inside the epidural space to have the risk of a more spinal cord injury. And also you can use the burr to apply the bone wax. That is a very interesting technique that you apply the bone wax. because in some situation, it is difficult for you to apply the bone wax using the elevator. And then it is the step-by-step approach to use the no-punch technique. The first way is to use the burr to find the cranial attachment of the ligament flavin, and then go to the caudal part. And then you go to the contralateral side, use the elevator to detach the ligament flavin off the under surface of the lamina, and you separate the superficial part and the deeper part. Then at this time, you can insert the high-speed drill into the space to remove, to decompress the contralateral side to the lateral recess, and also maybe you can go inside very deep to the nerve root, to the contralateral lateral recess. Then you use the curved osteotome to cut the undersurface of the contralateral facet joint. Because you cut off the attachment of the ligamentum flavin, then you can use the pituitary comb to remove the ligamentum flavin without using the punch. For the severe and the eviscerator side, you can also use the osteotome with the same manner to chop off the lamina in a very thin slice, and that will also detach the ligamentum flavin, because you just take over the attachment of the ligamentum flavin, then you can use pituitary comb to remove the ligamentum flavin in a whole piece without injury to the epidural, injury to the dura. And that is the final check for the complete decompression. So I developed a set of osteotome that with 3 different angles. One is a straight angle, and maybe the other is maybe 10 or 20 degree angles. A very, very thin and very narrow, about 4 millimeter wide only. So in the left side video, you can see that it's very efficient to undercut the ipsilateral facet joint. Then you can detach the bone, the lamina, and along with the ligamentum flavin. Easy and safe and clean. Then now in the video, we're cutting the SAP, the inner side of the SAP. After you cut over the chop of the inner side of the SAP, you can twist the osteotome and separate the fragment. Then you can see the nerve root is just underneath the bone fragment. Here inside the video is the ipsilateral nerve root, traversing nerve root. You just take out the lamina chips, then along with the ligamentum flavin. It is very safe. So that is another application of using the osteotome. When you want to do the foramen decompression, and you want to unroofing the nerve root, or you want to do the resection of the SAP, or you want to resect the marginal osteophyte inside the foramen. And after you resect the fragment, the nerve root, the exiting root is already exposed. You don't need to use the punch to invade the exiting root. And another advantage of using the osteotome is you can minimize the facet joint violation. Because when you use the punch is always straight or some curved. But if the opening of the punch is not big enough, you cannot remove the under part of the facet joint. But with the curved osteotome, you can remove only the under part of the facet joint to preserve most of the facet joint. And in our study, we can preserve the facet joint as much as 90% on the contralateral side and more than 80% on the ipsilateral side, with effective decompression of the spinal canal. And for the multiple level decompression, we can use this technique with efficiently with very good decompression effect and minimal damage to the paraspinal muscles. In our practice, we have performed more than 800 cases of UBE surgery until 2022, and we have a consecutive 700 cases without dural tear at all. So that is the advantages of such kind of no punch technique. So now we understand that practice not always makes perfect, unless you know how to avoid this mistake. That's why we introduced the no punch technique, because the punch is the most offending instrument to cause the dural tear. Thank you for your attention. 감사합니다.
Thank you very much for your wonderful lecture, Dr. Paul. I would actually have a question for you. What do you feel are the essential materials for a contralateral decompression? Is it possible for us to do with chisels the decompression of the contralateral side, and for example, the ULBD, and at the same time strip off the ligamentum flavum? What would you advise us?
I will preserve the ligamentum flavum to the very end of the surgery. And I will use the osteotome to chop off the under surface and the inner surface of the facet joint. That is the SAP, the inner part and the lower part of the SAP. But I will try very hard to preserve the facet joint. Yeah, that we can remove the ligamentum flavum along with the lamina and lamina bone chips. Yeah, that is. I think it is the most safe way to do the contralateral decompression, and it is very effective.
Okay. Thank you very much for your kind words. We'll now move on to our next program in our day. It will be the live surgeries that we'll have. It will be a pleasure for me to introduce our next surgeon of the day. That is Dr. Chede Jong, or also known as DJ Choi. So in the next couple of hours, we'll witness two of our live surgeries. Our first demonstration is Dr. Chede Jong, and he's from the Himnera Hospital in Busan, South Korea. He's not only one of the best instructors in the world in best biportal endoscopic spine surgery, but also has marked the field with extensive number of published papers and textbook contributions. He will guide us in how to perform the posterior cervical foraminotomy, showcasing his finesse and extensive experience. So in our first case, we have a 69-year-old patient with neck pain and left shoulder pain. Patient presented weakness in shoulder abduction and especially in elbow flexion and extension. Here are the X-ray images. And MRI images show the left foraminal stenosis at the C5, C6 level. For this patient, we would like to show you the posterior cervical foraminotomy being performed with the UB technique. We'll be in the following minutes live with our surgery. Please hold on with us and learn more on how to access our site in spineacademy.ac.
we will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The step-by-step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy.
We will now be with our first live surgery of the day. We'll get the images from the OR and we'll bring it to you.
펜 주시면 아까 내려놨어요. 네. 하고 요거 하고 스킨 미션 넣고 그다음에 요거 다일레이터 주시고 이렇게 주시면 됩니다. 네. Good morning, everyone. This is the case of C5-6 left side foraminal stenosis. Now we are trying to decompression the foramen using unilaterally biportal endoscopic surgery, surely BAS, surely UBE. So now this is a skin marking under the C-arm. We pose the C-arm upright standing, not tilting, not rotating. So this is a LC5-6 left side interlaminar space. So pose it. And the other one, another portal is 3 centimeter apart. Check on 3 centimeter apart distally. It's for instrument portal, working portal, and the proximal one is a scoping portal. I use a die for checking the level. So I put it the needle, spinal needle from the medial and trying to pose it in the lateral mass on okay, okay, in the middle, okay, around. I pose a spinal needle on around the joint, around the joint, and I injected one cc of the dye, and after that remove the spinal needle. When I put the scope, I found the blue print, then it's a correct level, so I don't need to check the C-arm anymore. So, and I choose and I make a two portal close to the midline as much as possible on not on the lateral mass. I make a portal as close to the medial side and make it transversely 1 centimeter apart and centimeter sized, and cut the fascia a little bit and 3 centimeter apart distally, and make another portal and cut the fascia. And using a muscle dilator, I put it medially and trying to landing on the facet and detach the deep muscles from the lamina. Everybody knows that the neck muscles has several layers, obliquely, transversely, reverse obliquely. So the fascia is not released yet. So using a dilator on, the direction is a little bit proximally, and I touch the bony laminar surface. I can feel it, the bony surface, and from the distally on. Okay, then I will show you the lateral view. Lateral 한번 보여주실래요? Okay, this is a partial laminar protrusion, C5-6 left to side, and you should remember this angle. The scope should be located a little proximal direction. Okay. You should hold it dry gauze when you, because when you put it the scope, your hands is wet, the water drop runs to the lens, and abruptly during the surgery the scope becomes very blurred. So always I use dry gauze over the overlapping, covering the scope. Okay, on. Okay, after that 대시안 빼셔도 되고요, 프락시말로 그냥 그대로 올라가셔도 되고요. 예. Okay, so after double check AP and lateral view, we can pose the exact level C5-6, and we don't need the CM anymore. So the CM will be retrieved. Now start the surgery. 이 shaper. 스컵 조금만 앞으로 당겨 주실래요? 타워 조금만 당겨 주실래요? 거꾸로 좀 꽂아 주세요. 네. So, after putting the scope, make the focus clear and shaking to and fro. Then the muscle, laminar muscle is already exposed. So, after that, putting the shaver. Okay, putting the shaver. Try to remove the rugged muscle. At first, before inserting a scope, I already put the dilator, muscle dilator, and detach the muscles from the base, so the basal muscle is elevated state. And I injected the dye, so the dye shows your way. So this point is exactly the L5-6 level. Okay, inhale. I pose the portal a little bit lower. So I call it this cranial caudal direction, medial to lateral inclination approach. So I can see I can see the LC5-6 joint rather than the LC5 lamina itself. So so when you put it the scope, and you can see these fat muscles, that is a 5-6 joint. So the V point is a little bit sometimes there's no V point, because we can see the lamina distal surface, not the dorsal surface. So it is already C5-6. Punchy E. And I'm trying to remove the soft tissue, and mostly the grandma has a very thin cortical bone, so we don't need a burr, only carry some punch. And I check the hardness of the bone, and I think it's very fragile. Okay. This view is not a vertical view. We just see the facet cranial to caudal direction, osteotom. So this is a dorsal surface, this is a distal surface. So straight. So using a straight chisel, Using a straight chisel, I just try to cut the distal surface, not the dorsal surface, and I get the space. So we call it inclination approach. I just make a crack. Yeah, only 1 or 2 millimeters. The chisel has 3 millimeters width. It's very narrow and much smaller than the lumbar spine device. So after cutting the distal edge, only 1 or 2 millimeters, that's enough to see the lower lamina SAP tip. So we can preserve the lamina as much as possible. So the one weak point of the PCF is multi-level decompression using a microscope, using a tubular retractor like that. Then we have to sacrifice the lamina much. So in multi-level decompression, we have some risks of the lamina fracture. But this kind of inclination accessing, we can preserve the lamina as much as possible. So in multi-level foraminal decompression, we can save the lamina, and there's a lowering the risk of the lamina fracture. So this is undersurface. Dorsal surface is here, and we can see from the undersurface, from the cranial quadrilateration, and we can directly see the undersurface. So the SAP, we can see the direct well. So this surface covers the SAP tip. So punchy. We can use a bar also, but because of the bone debris, frequently the surgical field is covered. So I should stop frequently the procedure. So I quit using the bar. Okay. 케어 작은 거. 안 되는데. 네, 케어를 좀 큰 거 줄래? This is low lamina SAP tip. 케어 큰 거, 작은 거 한번 체크해 주시고. 네, 자, 큰 거. 발판을, 오케이, on. A small soft tissue covers, little soft tissue covers your view. 자, also come straight. Okay. And this is a medial area, and this is a lateral area, so we should go to the foramen a little bit laterally. Go. This bone is very the bone is very fragile. Yeah. A little tapping is enough. Okay. And go. Okay. 펀치. 펀치 1mm도 이제 주셔도 되고요. 네. In the C-spine, the 2 millimeter calcium punch is a little bit bigger, so we use 1 millimeter calcium punch. Okay. Good. Now we can see the SAP tip. Okay, and the calcium punch 1mm. Okay, this is already SAP tip and punchy 1mm. 거꾸로. This is a 1 millimeter calcium punch, little by little. Resected. The SAP is resected. Very nice anesthesiologic condition with the help of the very nice performance of anesthesiologists. They're very clean surgical view. There's no bleeding. Very stable vital state. So C-spine. I'm also in a very early stage. After starting this surgery, I'm very scared of surgical approach. But after starting this UBE using endoscope, I can see the margin clearly between the structures, and I can access to the foramen with deeper with the preserving of the normal structures. So this cervical surgery becomes very, very safe and easy to me, and I think to the other surgeons also. 자, accurate. So laterally, proximally laterally, I decompress this SAP tip, and using a curette I can break in the piece pitches 작은 거. So finally we should break the SAP tip, and the foramen will must be open wider. So don't try to remove the ligament flavum first. So due to the stenosis and the adhesion, the vasculars are adhesion state, and the left hockey. Yeah, I use the 4 kind of chisels: straight, curved, pedicle, and hockey. Left side, hockey, curved one. And we can preserve the upper, and we can access to the deeper. Top, 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 top. Okay. Okay. Should it? This is a dura, and this is the axilla portion about the pedicle, and proximally this is a root. So root is adhesion because of the foraminal stenosis. So the vessels are adhesion state, and using a curette we can break it the SAP from the deeper and hooked out the fragment tissue 작은 거. Okay. Finally, we can this is the root. Okay. Top. We have to use the radio frequency with a very low voltage because it is used just beside the nerve structures. Okay. 다음에 this is 안녕하세요. It's ventral hockey pedicle chisel. This is a pedicle chisel, and anteriorly a little bit anteriorly 30-degree bending, and we can access to the sublaminar area, and we can decompress sublaminar area a little bit more, and it gives a little bit wider space for the foramen. So we don't need to excise the lamina fully over the root. Okay. Sometimes there is a rainy season, so we need a roof. We can give a roof, and sometimes there is a very sunny days, and we need an umbrella, and we need a shadow and a peaceful place for the root. So don't remove the lamina over the root. Only the root needs a little more space, and we can preserve the lamina as much possible, and can decompress the foramen well, and the root can live peacefully under the shadow of the root in the sunny days. Correct. And the root can be escaped from the big rain in the rainy season. Just remove the sublaminar area bony spur and the SAP spur. That's enough. It's only 5 millimeters pathology. It's not a big. The dorsal lamina is a normal structure, so it's not a pathology. So we should only the SAP tip is left, and I use the hockey once and the hockey once more. Okay. Now is the final pathology. Go. 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 I think everybody thinks that the chiseling and the hammering over the neck, near the brain, near the head, it is very dangerous. But in my eyes, I think the high-speed burr with the very high heat is using just around the root is more dangerous. Sure. There's a dura and the root and there's a tip. We can clearly see that the structures, and using a curette we can break down the safe tip. Okay, that is a real pathology at the final lesion. Okay, then after that we can, when we decrease the water, we can see the root dura pulsation well, and the local compression is released, and we can guess normally restore the circulation on okay, on. Small bulky radio frequency is very beneficial to the C spine, so it's mandatory you should use this one. On. Okay, this is axial portion. If there is a disc, you can execute it. You should excise it a little bit more laterally. A little bit laterally, it is a pedicular region, and you can excise it here and distally, and we can access we can make a little bit more free space, the axial portion, and from this point we can access to the disc space. But in this case, the disc is a little bit protrusion, but it's a hard disc, so we don't need to excise it. We just try to remove the small debris. So the foraminotomy is done. We can see the root clearly well. Okay, thank you very much. The surgery is finished, and you can join the lecture again, and you can spend a very, very nice Saturday today. I hope today, this day, will be the very best memorable day to you. Thank you very much, and thank you for the Professor Gon Choi to preparing this big conference. Thank you. Thanks so much. 네, 끝났습니다. 뭐 넣으시는 거 없나요? 네. 아니?
Now we're back. We hope you enjoyed the first surgery of our day, and we'll be back with live surgeries in a few moments as we prepare the next patient. So please stay with us and feel free to send your questions in the comment section, and we would also like for you to access and enjoy the Spine Academy website. Whatever questions you might have for the surgeon of the day, please leave it to us, and then we'll be following in the course of this didactic course to try to answer you in the best way possible.
will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The step-by-step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy. will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our Education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery.
We are now back with some of our live lectures. We'll follow with a live lecture before our next surgery. And it's my great pleasure and honor to introduce our next invitee. That's Dr. DJ Choi, one of the best biportal endoscopic spine instructors in Korea and in the world. Thank you, doctor, for having you this day. It's a wonderful opportunity.
Thank you for introducing me. Today is a very big date. And it's a very great privilege for me to stand with the great surgeons, Gon Choi, and Professor Bao, and Professor Alphonse Garcia, and Professor Donghwa Hung, and all of you. It is a beautiful Saturday in Korea, and it's a very good, nice time with your family. But don't be regret. You memorize this day is a very big day. Now I start my topics. Today my topic is about the decompression surgery for lumbar foraminal stenosis. I have two lectures. So in the morning, I will describe my experience of the foraminal decompression, and in the afternoon, I will focus on the L5 is around a problematic area, L5 and some foraminal decompression. Let's start. Lumbar foraminal stenosis instance is clinically 11% or radiographically 26%. That means it's so common. So 1 or 2 patients of lumbar radicular pain have combined with the foraminal problem. So always you should focus on the foramen, not the central itself. And postoperative spinal pain syndrome, PSPS. Previously we called it the failed back surgery syndrome. Anyways, 30% of the patients suffered from after the surgery and before the surgery, after the surgery, but most of them, they are combined with the foraminal problems. But so long time we neglected it. Because we are the fusion surgeon, open surgeon, so we focused on the central stenosis, so wider decompression of fusion itself. But the endoscopic surgeon, as an endoscopic surgeon's eyes, we have to check at every point, and we have to preserve the other facet stability and normal structures, and we definitely 100% detect the pathology and eliminate it. So anyway, we have to focus on the foramen. So after foraminal decompression, the local circulation, they recovered very, very beautifully and fast. And even during the surgery, the local circulation is recovered and the root swollen as a normal size. But the central stenosis and foraminal stenosis are combined together. Our eyes are just focused on the central stenosis, and the foramen is neglected. Due to the central stenosis, the patient has a stooping position, and the foramen is open a little bit wider. So L5 rotacium, the calf thigh, lateral side, and calf pain is there, but there's no anterior thigh pain. There's no L4 root pain. Then we think that, oh, there's a foraminal stenosis a little bit, just at a glance, but there's no L4 root symptom, then there's no pathology. No, definitely no, because the patient position because of the central stenosis. So after decompression of the L4-5 decompression, the patient can lift her back posteriorly, and the foramen is closed much more, and the patient suffered from the L4 root symptom, anterior thigh pain, immediately within a few days. So don't forget the foraminal problems. Sometimes we have the anatomic knowledge and experience. In some part, it could be called a preconception as an open spine surgeon. So the axial MRI shows foraminal stenosis left. Definitely there is a foraminal stenosis, and the sessile view shows a supra-articular process spurs impinging the nerve root. But the right side, the right foraminal stenosis, is the foramen is okay on the axial view, and the sessile view shows the foramen is okay, and the extraforaminal side there is a spur. Then we think that this spur could be a pathology, impinging, irritating the nerve root, or sometimes no. We have no convince because there's no paper, there's no textbook, there's no document about the exact reading about the meaning of the MRI and the spurs. So as an endoscopist, we should focus on such kind of small, delicate pathologies. In previously conventional microscopic approach to solve the foraminal problems, 1996, 30 years ago, and microscopically, medially and laterally foraminotomy, medial laminotomy and lateral foraminal laminotomy. Then between the approaches, the lamina becomes very thin, and ischemic fracture is so common. During the surgery, we don't know what happened to the lamina because the muscle covers the area. And after the surgery, the patient suffered from the back pain dynamically, and the radical pain is gone, and the back pain still left, and the patient suffered from the back pain when he and she is trying to stand up and the bending position. Then we just said that, oh, because of the disc rupture, the disc is becomes so weak because of your previous problems. So after the weather, not depending on the surgical procedures, your disc condition is not good, so you suffered from the chronic low back pain. No, after checking the CT, we can frequently find that ischemic fracture. So the other surgeons noticed that, so they use one approach, one side. So the left side, 2008, the transpedicular approach to preserving the lamina as much as possible, and through the foramen and decompression, the subpedicular area and the SAP tip. And the right side, after that, through the transforaminal approach, SAP fully resection and subpedicular decompression. So at that point, subpedicular decompression concept is coming out. So when the disc height collapse one side and the coronal tilting and the facet subluxation. Facet subluxation means it's a listhesis. A ventral slip happened and the root dorsal surface can be impinged by the undersurface of the pedicle, especially L4 and L5. So to decompress the foramen fully, sufficiently, in addition to the SAP recession, subpedicular decompression concept becomes more and more popular. But their result within 2 years, after 2 years of the surgery, 7% of nearly 8% of the revision surgery and transpedicular approach, and the transforaminal approach 20 to 30%. Why the decompression make more problem? Why? Later I will try to explain. It's just my guess. This is my theory, and I try to explain why wider decompression is much worse than the little decompression. So why they satisfied? First, the dual approach laminar fracture happened, and the transforaminal is too small, so it is insufficient decompression. Is the conclusion of their papers. And the transforaminal approach, judicious decompression, SAP transpedicular, why the decompression of foramen, why the symptom recurs, and where the symptom occurs. So, in these days, many surgeons perform the foraminal decompression using UBE and full endoscopic surgery, and they reported their experience. So, the first one is eliminate foraminal pathology. Then we should know what is the foraminal pathology. And the second is we should preserve the functional structures. Just why the decompression around the foramen is not the answer. And our endoscopic approach, full endoscopy or UV approach, biportal approach is reasonable, or we have to change something. We should talking about these 3 topics. So the first one is about the foraminal pathology. Actually, in my experience and the other papers, there are 7 pathologies. You can list it on the 7 pathologies around the foramen. We should know well the foraminal lumbar disc herniation, well known, and the superior articular process hypertrophy, well known. And ligament flabum hypertrophy is not a big one because when accessing to the foramen through the dissection, the ligament flabum is easily eliminated. So the foraminal ligament disc herniation and the SAP is very, very notorious one. And how about the subpedicular kinking? I already said it, so you should know that, and there are many papers comment about that. And have you ever heard about the isthmic spur or endoplate spur? Okay, you know that. But which endoplate spur is pathology and which could be neglected? There is no papers, there is no report, there is no criteria on the radiologically. So as an endoscopic surgeon, so we should make this one as a standard protocol 1 by 1. So on the right side, foraminal disc rupture, and everybody knows, always a huge big disc rupture or migration at the foramen, and the root is impinged, and the root, even the root looks so swollen. It's very painful, so pity. But on the right side, axial humeral, have you ever can you detect the real pathology on the axial view, the foramen to extraforaminal area? No, there's nothing. It's sometimes some pathology shows nothing. So we should use a CT rather than MR view. So they have to check in the CT shows subpedicular isthmic spur. It's very huge, and the foramen dimension becomes narrower than the 7 millimeters, and the root can be impinged. So after the transforaminal approach, resecting the isthmus lateral to ventral area, we can remove the huge spurs. So sometimes the CT is better than the MRI, especially on the foraminal pathologies. So in the morning session, I focused on the disc herniation and the supraarticular process tip and the junctional isthmic spur. And in the afternoon, L5S1 problems, pedicle kinking and the plate spur and the Favre syndrome. So let's talk about the lumbar disc herniation. Actually, 455S1, there's a wide interlaminar space, so the accessing in open surgery, in endoscopy, no cares, no cares. Is not easy, but it's safe, and you can successfully do the discectomy well. I totally agree. But in the higher lumbar disc herniation is very challenging. Maybe 20, 30 years papers in Korea, and we can review that. In the upper lumbar disc herniation, especially migration in the higher lumbar, L1, 2, 3, 4, the lumbar disc herniation. Fusion is the one of the indication, because when during the surgery in posterior side approach, and we should retract the dura and the root, and there is so much bleeding, and the spinal canal is too narrow, so many neurologists. So the 50% of the surgeries shows a better result. So we need a new strategy. Why upper lumbar disc herniation is challenging? Because the corners of medullaris ended between the L2 S1 normally, but sometimes higher L1, but sometimes L3. So when you just without caution, we just access the posterior side and retract the dura a little bit, and the corners of medullaris is retracted. Especially most surgeons in this state, the bipolar surgeons are still learning curve, including me. I just performed L4-5 long times, hundreds of cases, but L1-2, 1-2, 3 of migration is very rare cases. So when I tried that, if I had not do the surgery, done more than 100 cases, one L1 to migration disc, then it's still learning curve in the case. So posterior approach from the interlaminar space to the migration disc. Migration disc means the disc fragment should be located in just the pedicular area, mid area. Then it's too long, more than 2 and 3 centimeters from the interlaminar space to the target. Then we should sacrifice of the lamina. There is no space. There is no space. So especially on the right side approach, we should sacrifice the lamina totally. But the transforaminal approach, from the foramen to pedicle, is only less than 1 centimeters. And when you access to the foramen, the axilla is open, and through the axilla, just 5 to 7 millimeters approximately, there is a pedicle middle space. So we can easily remove the real fragment under very nice view. So the transforaminal approach is very best choice. And the foraminal stenosis 2, 3, 4, 5 is the foraminal stenosis, and the 2 to 3 down migration disc. Down migration disc should be accessed to the posterior side and not the foramen, because foraminal decompression we can do that, but through the foramen we are trying to remove the very, very far down migration disc. We cannot access there because from the end plate 12 millimeters below is a far down migration. Then there is a pedicular area. 12 millimeters is pedicular area, and underneath there is a root and there is a fragment. That means the fragment is a jump over the nerve root, and it should be located actually of the lower level. So from the upper to this area is too far, because the pedicle and because the root we cannot access to this axilla portion. So a little bit down migration, we can access the fragment through the foramen at the same level, but 12 millimeters more farther down migration, because of the nerve root we cannot access to the axilla portion. So the best point is a low level of foraminal approach. It can be reasonable, but the best thing is a posterior approach. Posterior approach is reasonable. The other things, central, foramen, migration in higher lumbar disc herniation, you should choose transforaminal approach. So the very best choice, very best indication of the full endoscopic surgery, I think, is upper lumbar disc herniation. And we move to the supraarticular process, surely SAP. SAP has a functional structures. Don't sacrifice full of them. Because the SAP looks like a curved structure, like a triangular shape. It's not just a simple one structure. So the ventral area, ventral surface, ventral plane can face the nerve root and can irritate the nerve root. And the lateral plane is located far from the nerve root, so it never touches the nerve root. So the ventral plane, ventral area is a pathology, and the lateral plane is not a pathology. Then why lateral plane is important? It is just located in the air. No, actually, the ventral plane. And when the disc height is good and the ventral plane is located apart from the nerve root, but the disc height collapse and frequently stressing and the SAP hypertrophy, then the ventral plane compress the nerve root. Then what is the function of the lateral plane? When the disc height collapse, the lateral plane supported the TP isthmus junction and stabilize the facet not to further decrease the foramen. So the lateral plane is very important. In the different view, the ventral plane is here, and the lateral plane is a blue one. So it is located far from the nerve root. So when the disc height collapsed, the lateral plane is close to the TP isthmus junction, and it stabilizes the facet. Actually, we call it the propping mechanism. Propping means supporting each other. So there is a propping inside the mechanism already. It's a real facet, inferior articular process and the supraarticular process. There is a joint, is a propping inside. So normal functional structures supporting the facet stability. When the disc height collapse, the secondary stabilizer mechanism is starting, and we call it propping outside. It's a real function of the lateral plane of the SAP. So in previous microscopic operation, foraminal stenosis is coming from the dynamic pathology SAP itself. So we should sacrifice of the SAP, then we can make a foramen wider, and we can solve the foraminal problems. So using biportal approach, when I started the surgery, I sacrificed and the lateral plane fully, and I feel very satisfied. But the patient does not feel satisfied, because after sacrificing the SAP lateral plane, the further collapse happened. Already there is a foraminal stenosis. That means the disc function is decreased and they start to decrease down. So after supporting the pillar, the lateral propping mechanism, the further collapsing of the disc happened very, very fastly, and 1 or 2 or 3 months later, the spinal column is collapsed into one side, and the scoliosis happened. Even when the disc height is collapsed more than 50 to 80%, we believe that it already stabilized, no more prolapse, no more collapsing anymore, because the disc is already collapsed more than 50 to 80%. No. Even the totally collapse of the disc space, the end plate start to be fractured. So the pain is started. So maybe it's my guess. I'm sorry to the authors of the papers. Insufficient decompression is okay. Just insufficient is sufficient. So because of insufficient decompression, only 7% of the one more decompression needed is okay, acceptable. But even the wider foraminotomy after sacrificing fully of the SAP, 30% of the patient suffered from pain and need a revision surgery in 2 years. Why? Because we sacrifice the SAP lateral plane and we sacrifice the propping mechanism. There's no more supporting structure on that side of the foramen. So we have to choose the contralateral approach. Control approach means we access to the foramen posteriorly and access to the upper side, mainly pain side. Standing on the upper side, access to the obliquely to the foramen and inside the ventral plane of the SAP only. Lateral plane is still preserved. That is a very, very ideal approach. So we should guess The ventral plan is Samsung, and the lateral plan is iPhone. So the ventral plan, lateral plan. The structure looks 3D structures looks like that. So the contralateral approach means ventral half tip SAPT real pathology is sacrificed, and the root comes out, so the ventral edge can be sacrificed, and most of the lateral plane is still preserved and is supported the TP isthmus junction, the white box. And when we choose the transforaminal approach, we have to sacrifice the lateral plane first and then access to the foramen. So we sacrifice the propping mechanism. So it's a contralateral approach, standing on the left side, and now we are seeing on the right side after discectomy, and there's a nerve root. We can fully decompression. So using one approach on the left side, we can decompress the central, and we can decompress the foramen the opposite side. So this contralateral approach is very ideal, very powerful approach. Only it is very nice in the full endoscopic or UBE surgery. And the foraminal stenosis frequently combined with the L5S1. But the L5S1, the central canal is very wide, so there's a little problems in the lateral recess and the central itself. So the ligament flavum is not a pathology. So you can preserve the ligament flavum in the middle and just jump over the ligament flavum and access to the foraminal contralateral side. When we preserve the ligament flavum well, then there's no epidural bleeding, and the surgery can be done under the clear surgical field, and we can decompress the ventral SAP plan, and the ligament flavum is preserved, so that there's no dura injury at the dura tear, the nerve root, the adhesion like that. So the contralateral approach at the 5S1 is a very, very nice approach. But sometimes we have to choose transforaminal approach. Is there foraminal disc combined or Favre syndrome? Then at the time the contralateral approach sometimes is limited. So then how to overcome the conventional transforaminal approach? We have to start this transforaminal approach a little bit farther laterally from the conventional UBE portal. Then we can access to the foramen ventral side, and we don't need to see the isthmus and the posterior side. So we can see the lateral plan of the SAP, and through the 3 centimeter apart from the pedicular lateral margin, then we can directly access to the ventral side and excise the ventral plane, and the lateral plane is still preserved. So the only ventral plane is excised. So when we're using the P+3 portals, that means 3 centimeter apart from the lateral margin of the pedicle. That is a skin marking and it's a portal. Then we can access to the ventral plane and excise successfully of the ventral spur, but still the lateral plane is preserved. Preoperatively, postoperatively, lateral plane supporting the PP isthmus junction can be preserved, and the propping mechanism is preserved, and no more disc height collapse. And after foraminal decompression, then the L5 and the root can live happily ever after. So now we've moved another new pathology, isthmic spur. Isthmic spur can be generated, can be grow because of the SAP and the stress on the SAP and the upper lamina, the ventral portion. Or sometimes if there is coronal tilting and the stress is moving to the lateral side and the facet subluxation and the spur growing from not the ventral itself and the outside also. So there is no such kind of, we call it seal, is like a step, is a protruded bony portion. It becomes because of the cortical hypertrophy, which is coming from the stress between the SAP tip and the ventral surface of the inferior articular process. Then the cortical bone becomes thickening, and there is some seal portion, and it can compress little by little. It compress the nerve root to sometimes grows very bigger, and it's another stopper not to decrease the foraminal height. Especially these spurs get growing of the L5 as because of lumbosacral angle. If the is L45, if there is a lordosis is preserved well, the SAP can be growing proximally and it can compress nerve root, but there is no isthmic spur. So the kyphoid, because of lumbar sacral angle, the ventral isthmic spur can be grow up. But in degenerative scoliosis, when the disc height collapses to one side and the stress is going to the one side, and the SAP and the TP isthmus junction is stressed a long time, and the cortical thickening happened, and there is some spur. It's very tiny, little, tiny the radiologic change, but we should focus on, as endoscopists, we should focus on such kind of pathologies. So when the disc is collapsed and there's subluxation and TP isthmus junction is frequently fighting, and the spur is growing isthmic outside. So we should focus then. So in the MRI shows something, but we cannot catch as well. It could be pain or it could not be. And the foraminal side looks high signal, then we just think that simply think that, oh, there's no pathology, the foramen opens well. But in the real, in the surgical field, we can find that the junctional isthmic spur outgrowing of the outside of the foramen, growing can compress the nerve root after resection, that the nerve root is impinged between the disc and the junctional isthmic spur at the foramen. So such kind of things could be a pathology. Now we have to do some more technically sufficient and successful decompression. What is the technical point? The first, I use P+3 portals. That means under the CM we can check the margins of the pedicle, and through the lateral margin of the pedicle 3 centimeter apart, we can make 2 portals on the skin, and through the portal we can access. We are trying to landing on the TP, transverse process border, not the isthmus itself. So we can do that like this design. And the first, we don't need to landing. And we don't need to landing on the isthmus itself as a conventional UV style. You have your own style, but it's my style. So I started this surgery, transforaminal approach P+D, because we started the portal, make a portal, pedicle outlines. Even using a skin elasticity, the view to the access to the foramen deeper is limited, so the real ventral plane is not limited, and so we have to excise the isthmic portion, and there becomes a higher risk of isthmic fracture. So the P+3 portal becomes a little bit standard, and we should landing on the transverse process first, because isthmic portion, there are so many vessels, and there's so many bleedings, so we spend much time to fighting the bleedings. So safely we should landing on the TP transverse first is this portion, and then we can now from the scoping portal, we can landing on the distal half of the TP and trying to go to the foramen directly. We don't need to expose the distal transverse process. On the right side, L5 TP should be a scoping TP and landing on the proximal half and go to the foramen directly. We don't need to exposing L4. Why we should landing on the distal half? Because the proximal half 9 o'clock duration, there is a inferior articular branch on the left side. On the right side approach, the 6 o'clock and 12 o'clock is main bleeding comes out, always the same direction and same point. We should remember where the bleeding comes out, then you can expect which comes happening. Bleeding comes in at such procedure point, and you can preparing the coagulation. So you can coagulation that best before big bleeding. So when you put the scope, there is the muscles and fats, and we just see some part of the bony surface transverse process, and there are so many scattered bleedings. It's just coming from the muscle. No, there's a pattern. So all the vessels have their own names. When you put the scope and there is a big bleeding, that bleeding has a same side, same focus, same direction. So we call it the vascular geometry. So you should remember that the vessel geometry then is navigation, so you can coagulate that, and the surgery becomes much more easier and safer, and you can decrease the operating time. So when you, after removing the foramen ligament flavum, and just in the middle of the nerve root, there's a radical artery, and just proximal of the pedicle, there is a suprapedicular artery. The big bleeding is coming out after phlebectomy, so you can expect that. So this is when you put the scopes landing on the TP distal portion, and after coagulation, then you should try to find the supraarticular process. Then you should jump over the musculotendinous bundle attaching the accessory process. So when you put the scope, always we can see these muscle fibers, musculotendinous fibers attaching the accessory process. Don't go under the accessory process, then you are going to the abdomen directly, and the water is infused to the abdomen. Then and the right side approach landing on the TP and follow the 2 o'clock direction proximally. Right side is very easy, just to follow the bony margins, and it leads to the SAP tip. So when you neglected the touch down the TP and jump over the musculotendinous bundle, when you go to under the musculotendinous bundle and the scope goes to the abdomen and infuse the water in the abdomen and thorax, you make a hydroperitoneum. Sometimes you can disorientation, and you boring off the vertebral body of the one side, and just the stop of the very big vessels. It's very lucky, and there is a hematoma. So orientation in transfemoral approach is very, very important. So just remember that touch down the TP and jump over the musculotendinous bundle. And then somebody asked me, and how can we see the nerve root we did not without eliminating of the lateral plane of the SAP? Then you should try to excise the distal transverse process margin. Then it's just the leading is connected with the pedicle. Just under the pedicle, there must be a nerve root. So after excising the distal part of the transverse process, then we can expose the pedicle, lateral part, and the root should be there. So without excising SAP, we can expose the nerve root fully. So I started this surgery 10 years. It's very lucky, and I see many things. So my recommendation is technique is a very simple, and you just need 1 or 2 or 3 trials. But the change of thinking is very, very hard, because you learn that as a big surgery. So please, let's try. Just to change a little. Just to change a little of your thinking, little of your concept. Then we will be a very great endoscopist. Thank you.
Thank you for your wonderful lecture, Dr. DJ Choi. I think sometimes it's overlooked, most of foraminal pathologies, and we see back in our clinics our patients with the recurrent pain at the same time. I think that we'll have a greater understanding for why it might happen, and also I'm looking forward for the next class as well. So we're moving forward for our next live surgery. Our second live surgery will have the privilege to witness the collaboration effort of 2 distinguished surgeons, Dr. Paul and Dr. Gun Choi. who will perform a unilateral laminectomy with bilateral decompression, ULBD, and laminectomy with the biportal technique. We're going to present our second case of the day, a 55-year-old female patient with bilateral leg pain, worst in the right side, and low back pain. This patient has been suffering for the symptoms for 4 years, but worsened in 2 months. This patient presented right-sided weakness for hip flexion, knee extension, and also diminished knee jerk in both sides. Previous treatment with percutaneous epidural neuroplasty was also done in the prior year. Here are the following exams. In this image, we can clearly see a 3-4 level central canal stenosis. There's also a down-migrated disc herniation, low grade. 4-5 levels we also see as patient had symptoms mostly to the right side but also to the left. In a few moments we will be sharing our images of our OR and sharing the live surgeries with you. Please stay tuned.
Thank you very much. That's good. Now today we're going to perform a 2-level decompression using the UBE technique, L4-5 and the L3-4 decompression using the ULBD. So we will do bilateral decompression, and there is a small disc at the L3-4 level, but I think the disc is very small that we don't need to take it out. If there is a ruptured disc, I will try to take it out. The target point is at the spinal laminal junction, on. And that's L4-5, and then on. That's L3-4. And the skin incision will be on the on, at the lower margin of in the laminar space. And the upper margin, on, will be at the lower pedicle level, L3. So we now start our surgery. We will do the skin incision first. That is the patient. 10. The patient is moving. Okay to go? Yeah, the retractor. The scope. knife. Oh, thank you. The scope? No, the scope. Is that a 30-degree scope or a 0-degree? The 30-degree or 0-degree? Excuse me? The scope? 0? I mean, do we have a 30-degree scope? Okay, also here. Yeah. Wait a moment. Yeah. Okay, we change to the 30-degree scope. Mm-hmm. I love to use the 30-degree scope because the viewing angle is wider and oh, the different sheets, okay. Okay, okay. Yes, that's good. Thank you, thank you. Oh, we don't need the Siam, please. Yeah. We don't need the Siam. Right, fur. This patient's bone quality is very good. That's up here. No function. No function here. Now the first step is to find the cranial attachment of the ligamentum flavum. You can see here a very small opening over the cranial end of the ligamentum flavum here. Then we move to the next step to go to the caudal part. So here. Elevator. You can see we should identify some anatomical landmark under the endoscope. That is the margin of the facet joint, and that is the lower lamina, the L5 lamina, the cranial, the superior margin of L5 lamina. So we move from here to the contralateral side. This come. This come. Pituitary come. So here. How about the power of the Delphi? Please give me the maximum power. The maximum power? Thank you. Now we are drilling the upper margin of the inferior lamina, L5 lamina, superior margin of L5 lamina to find the caudal attachment of the ligamentum flavum. Okay, that's the caudal attachment of the ligamentum flavum. Then we go to the contralateral side along the lamina. Elevator. And a very important part of the surgery is to detach the ligamentum flavum from the under surface of the lamina to make a room for the electric burr to enter into this space. Yep, that's okay. The osteotome, my osteotome. I need someone to hammer the osteotome for me. Here. Thank you. And again. Elevator. Okay, thank you. That's okay. since the ligamentum flavum is still there, so if you insert the burr into the space between the ligamentum flavum and the lamina, it is safe. I'll take some apart. Do we have a curved pituitary column? Maybe we do the contralateral ipsilateral first. Here, hammer. Okay, face. And more. Okay, no problem. Go. Go. Thank you. Okay, go. 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 The curve, less curved one. This one. Okay, go. Go, it's safe. Go, go, go. That part is safe. Then we'll detach this part. So here. Along the big curved one. Okay, go. Oh, good. Okay, go. 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 That's curve one. Okay. The most curved one. Go. Go, go, go. Okay. Okay. Curious. discount. You see that there's a central fold beneath the ligamentum flavum, the curved one. Oh, it is smooth. Correct. Yeah, discount. No. Discount. Okay, let's go to the other part. There's now to curate. Discount. The curved one. curved also, Tom? Okay. Okay. Go. Curate the smaller one. Shuttle. Okay, that should be the last part. Okay, smaller curve. Shuttle. Okay. One more. Okay, go. Good, good, good. Now you can see all the nerve, yeah, completely decompressed. Yeah. Do we need to take a photo? Yeah, the contralateral nerve root. Also here. We use the small one. That's the first time you use the small one. Ah, good, good. Because this patient's symptom is local, major symptom is on the right side, so the right side nerve root should be explored completely. And the left side is just for decompression. The main focus is the left side, lateral recess, and the left side nerve root. Okay, done. Now check bleeding. That is a contralateral disc space. Curate small one. Straight one. Okay, change to the bigger one. Bigger one will be okay. The curved one. Oh no no. Yes. Okay, change to smaller one. Okay, bone wax. Okay, bone wax. The bone wax should be applied at the tip. At the tip, that we can use both sides. No more bleeding. Not much bleeding. The bigger one. Small discount. Okay, let's now move to the next level. Knife. Later? No, not yet. function. Okay. This come, big one. And that's the bird, diamond bird. Elevator. 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 better. Circle, curved one. Watch out. Okay. 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 Small curved one. Okay. Go, go, go. Go. Okay, go. Okay, go. Go. It is okay. Go. It's very safe. Go. The right one. Okay, go. Okay. Then go. Okay. Curate. Elevator first. Discount. Curate. the straight one. Also don't curve the one. Okay, go. Too much. Okay, go. Okay, okay. Yeah. Okay, go. Go. Okay, just safe. Just a go. Go. Alright, go. Go. Go, go, go. Don't be afraid. Okay. And this part. My assistant never hesitate. They just go. Okay. Okay, that's good. Curve the one. I cannot hold it. This is not powerful. Kill it. What's your home? I will do the final chop. Okay, go. Go, go, go. And go. Sorry. Here. Go. Go, go, go. Okay. Almost done. Kill it. The curved one. Box. accurate. Big one, big one. Small discount. Curved one. Curved here. Okay, so yes, small accurate. And now there's the contralateral nerve root. And the lateral recess all clear. Bone wax. Oh, Dr. Gong Choi, the surgery is almost complete. See, final check. Small curved one. Hmm? The root? Here? Curate, more, big one. You're worried about that one? I will use osteotome, like big one. Right, go. Sorry. One more. Sorry. Oh, okay, go. One more. One more. Okay. Okay. Even better. It's more accurate. Okay. Okay, let's go. Huh? Pyria. What is Pyria? 漂亮 You say Chinese. Thank you. Okay. That is we do two-level decompression without use the punch. Yeah? No punch at all.
So it was a great surgery that we followed right now for our second demonstration of the day. In a couple of minutes, Dr. Paul will join us and will give us in his next lecture. So Dr. Paul will be joining us in a couple of minutes, and now we're advancing to a little bit of more advanced techniques on unilateral biportal endoscopic spine surgery. And he'll give us a lecture of surgical techniques, pitfalls, treatment results of biportal endoscopic transforaminal lumbar interbody fusion. So please stay tuned. In the next couple of minutes, we'll begin our next lecture.
will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The step-by-step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy. show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The step-by-step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy. will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The step-by-step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy.
We're now returning to our lectures, and I would like to give the word to Dr. Pao for sharing his expertise on bipolar endoscopic transforaminal lumbar interbody fusion. Thanks to be with us, Dr. Pao.
Thank you. Everyone, good afternoon. It's me again. I'm Dr. Pao from Taiwan. The next topic I'm going to share is the bipolar endoscopic lumbar interbody fusion. And I prefer to use the double cages inside the disc space. Now, before the endoscopic surgery, I usually perform the lumbar interbody fusion using the MIST leaf technique, using the tubular retractor system. The result is very good. We have performed already more than 800 cases. The postoperative result is very good with a decreased ODI and a very increased, significant increase of a JOA score. And the operation time is also acceptable when the size is very good, but sometimes we need a blood transfusion for these patients. Although the clinical result is very good, but the radiological results are not as good as we expected. We think that the fusion could be very good, but if we use the CT scan to follow up this patient, we see there is some, the fusion is successful, but there are some subsidence, significant ratio of subsidence and subchondral cysts. Maybe you can call it osteolysis around the cage. And even in a 2-level, or when we use the double cages to increase the footprint, there is still we can noted some cases with end plate osteolysis and cage subsidence. So since 2018, we started to use the UBE to replace the traditional tubular retractor system surgery. Now I'm sorry. I'm going to introduce you the BET leaf using the double cage technique. And we know that the endoscopic big fusion, we have two trends. One trend is the camping approach. The other trend is a posterior lateral approach, using endoscopic system. The main differences is the way of the direct decompression. When you use the transcamping approach, you use indirect decompression concept. But when you do the posterior lateral approach, the ends of the decompression is direct decompression. You need to decompress the bilateral lateral recess, the central canal, and also the foramen. So we prefer the posterior lateral approach, as also called the transforaminal approach, to accomplish the direct decompression, because most of our patients had a severe neural stenosis. That's a schematic that we're going to use when I do the BET leaf. The skin incision is two parallel skin incision lateral to the lateral pedicle line, about 1 centimeter or 1.5 centimeter, depending on the patient's body habitus. And we create another independent skin incision to insert the endoscope. We use the mini Willis intermuscular approach, just like we did in using the tubular retractor system, because we want to minimize the muscle injury. Because when we use the intermuscular approach, the multifidus muscle and the longissimus muscle will be left untouched. That is the illustration show you how we approach into the interlaminar space. The first is identify the intermuscular plane, and then we resect the unilateral facet joint completely, and then we go using the ULBD technique to do the bilateral decompression. That is a triangulation. Usually we can localize the triangulation point at the spinal laminar junction, just as we did for the decompression ULBD alone. Or maybe you can dock in on the isthmus. Either way, it will be very good. And I will show you step-by-step process. The first step is to stocking down the spinal process and using the bird to do the laminotomy to find the proximal junction or the attachment, cranial attachment of the ligamentum flavum. And then we use the bird to do the, and then we go to the epicyclator side to identify the isthmus or the pars interarticularis. Then we use the to identify this pars interarticularis, and then we use the osteotome to chop off the inferior articular process. And the bone chips will be used in the disc space as a bone graft, as an auto bone graft. And then under the endoscope, the process is easy to perform, and because there is no bleeding, so you can use the osteotome to chop off the IAP into small pieces and take it out smoothly. And then we use the bird to continue our decompression to the contralateral side. If you did it from the right side approach, when you do the sublaminar approach, remember to reverse it to the reverse mode, just like I present in this morning. The reverse mode can prevent the unwanted accidental dural injury. Then we create the transformational route. This will remove all the SAP and down to the foramen. And this part you can use the burr or you can use the osteotome. Either way is okay. But when you use the osteotome, there might be more bleeding from the cancerous bone. If you use the burr, it is more gentle and it is more easy to control. When a bone detachment of the ligamentum flavum was identified, they could use the elevator to elevate the ligamentum flavum safely. They use the elevator to separate the underlying adhesion and the granulation inflammation, that you can remove the ligamentum flavum safely without the damage to the dural tissue. So further, we can refine our transforaminal route if the space is not good enough. So after all the decompression, you can easily identify the Kempin's triangle. Or also you can identify the transverse process, the traversing the root, the exiting root, and the Kempin's triangle clearly. Then you use the knife to do a durotomy, and use the to do the disc preparation. This instrument is designed by myself. I call it the end plate stripper. It has three-way, the curved three-way. And the tip is very sharp, but it's a wrong shape. And you can strip over the cartilage end plate off the bony end plate without injury to the bony end plate. In that way, you can separate the cartilage end plate and remove the cartilage end plate as a whole piece, as a big pieces. We never use the shaver provided by the company, because when you use the shaver, there is a risk of damage to the subcondylar bone that will increase the risk of cage subsidence. And then after you have a very good end plate preparation, you should observe that the end plate, the cartilage end plate is completely removed, and the bony end plate is well preserved. That is the end plate, cartilage end plate, and the disc that we removed using the more conservative, more gentle approach. Then you can use the trial to determine the appropriate size of your cage. There's no need to use any retractor because the space is big enough for the Kempin's triangle. And when you want to approach to the contralateral side, you can use an anchor, the dural anchor that is also developed by myself. This anchor can be used to retract the dura medially. Then when you put in the cage, the trial, or the bone graft, you don't need to use any retractor. You just insert the cage in, insert the instrument in. Yeah, this animation will show you how we insert the sequential insertion of the double cage. And that is the dura anchor that I told you. I use the dura anchor to retract the dura medially and insert the oblique cage. In that way, the oblique cage can be inserted to the contralateral side, and in that way, we can also distract the contralateral disc space to make it even. I will show you the separated steps of. And for insertion of the bone graft amount is also very important. So we use a cartridge bone graft impactor. That impactor can help us to insert as much bone graft as we want. And this cartridge is the bone graft can be impacted into the cartridge bone graft outside on the operation table by the assistant, then handed to the surgeon and insert the bone graft using the straight-in method. And the ideal position of the cage, the first cage is a vertical cage, so the cage should be just lateral to the dura. In that way, insert into the Kempin's triangle. That the cage is very safe to insert without any retraction. And the contralateral cage should be inserted obliquely, and the end of the cage should be passed across the midline. And on the lateral view, the cage should be should be flush the anterior vertebral border. That is, it should be aligned with the anterior vertebral border. In that way, the cage can be put as anterior as possible. That can increase the lordosis and prevent the posterior migration of the cage. And immediately post-operative CT scan, you can see that the cage was evenly distributed in the disc space, and the disc space is distracted with filled in with a lot of amount of bone graft. And that is why we use the double cage. And you can also use the double cage to distract the disc space. When you insert the first cage will be used as a bone disc space distractor. Then you can do further disc preparation, or you can insert a large amount of bone graft inside the empty space. So in the post-operative X-ray, you can see clearly there is the space between two cages is filled with a lot of amount of bone graft. Even on the X-ray, you can see there is a amount of bone graft between the cage. And it is a bone graft impactor. So after that, you can see there's a lot of bone graft inside the disc space. That can help to increase the fusion rate. For the disc spondylolisthesis, we can also use the cantilever method of the pedicle screw to reduce the spondylolisthesis. And when you put in the cage appropriately in the appropriate position, you can also distract the contralateral collapse the disc space to correct some deformation over a coronal plane, the malalignment. In this case, the coronal plane scoliosis was corrected by using the distraction of the cage. So correction of the kyphosis can also be done using this technique. That is a post-operative surgical wound. It is very cosmetic. For one segment fusion, the wound size is about 2.5 centimeter, and for the two segment fusion, it's about 4 centimeter. The right side approach did different with right side approach because of the anatomical consideration. Usually, I like to perform the interbody fusion from the right side approach, and the illustration show you how the scope and the surgical instrument was placed into working space. But when you do the left side approach, the endoscopic portal is different. It's like we do in the UBE decompression. It's at the medial pedicle line and the junction of the inferior pedicle line. And the differences between the right side approach and the left side approach, it depends on if you are a right-handed surgeon or left-handed surgeon. As for me, I am a right-handed surgeon, so right side approach for interbody fusion is better for me. And this illustration show you that if you use the right hand to handle your instrument, then you can easily go into the interbody space. But if you change it to the left side approach, your instrument will be obstructed by the facet joint and also the spondylolisthesis vertebral body. And when you insert the cage, is the same concept. You can insert the cage smoothly from right side approach. And if you use the left side approach, the cage insertion may be a little bit difficult. It is also can be done by left side approach, but it's more difficult. So for right or left side approach, right side approach is my preferred choice. But when the patient has a concomitant foraminal stenosis at the left side, or there's a or the patient has a locked facet joint on the left side require release, then I will do the interbody fusion from left side, although it is somewhat more difficult. We also developed some special instruments, just like I mentioned, the bone graft impactor, the end plate stripper, and the osteotome that I showed you this morning, or in the operation room. We have a whole set of UB specialized instrument, but now the instrument is only available in Taiwan. The local company did not prepare it well to release in worldwide. So for the clinical treatment result, we have I want to show you the initial result for 89 patients with 120 and 120 segment of a BETD in our hospital from 2019 to 2021. The diagnosis is mostly spondylolisthesis, and the one segment or two segment fusion is most of the patients are one or two segment fusion. The most segment are L4-5, then followed by L3-4. Now, why we use the double cage? Because the double cages provide a bigger footprint with better initial stability and a less likely chance of cage subsidence. And theoretically, there will be a higher fusion rate. That is our results. Our patient had a significant improvement, and clinically, that is reflected by a significantly lower VAS score for leg pain and back pain, and ODI, and significant increase of a JOA score. And no patient needs blood transfusion. The follow-up is about 15.5 months. And there is no dural tear, there is no neurological complication, no posterior cage migration in our series. There is only one epidural hematoma and the one TPS malposition. We treated conservatively, but we do have two cases need a revision surgery because of wrong level surgery, and one case with TPS malposition. The admission time is significantly reduced from 7.4 for the tubular retractor system, and to reduce to 5.9 for the BET leaf. And the postoperative MRI can show you the nerve decompression is very good bilaterally and with minimal soft tissue damage. And the reduction of the spondylolisthesis can be accomplished in 87% of our patients. We use the CT scan to evaluate the fusion result, just as we mentioned earlier in this presentation. Our main purpose is to improve the fusion rate using the biportal endoscopic technique. And our fusion rate is about 93% with a successful fusion using the Breedwell classification system. They are most of them are grade 1, very successful fusion. And we noted, we further analyzed that most of the fusion occurred at the area between the cage, that is extra cage bone bridging. And there's no case fused with only intra-cage bone bridge. So we think the bone graft, the amount of the bone graft or the bone graft between the cage, outside of the cage is very important, and the disc will be a simple disc distractor to provide mechanical stability. And because we use two different cages, we also observed that the cage subsidence has higher incidence on the peak cage side than the composite cage side. The composite cage side has a pure peak core with outer titanium plate on the superior and inferior bony interface. but the significance are, most of the significance are not significant with less than 2 millimeter subsidence, and but we do observe that the peak cage has higher incidence of cage subsidence. So that is the CD follow-up for our patient. That the fusion rate is very, very high, and you can see that at the 1 year CD scan, there is a bridging bone outside the cage and inside the cage, and the fusion mass is very big, very beautiful. And it's also 2-level fusion. You can see that it's only 1 year CD follow-up, but it's just very solid fusion. Very beautiful fusion. Is much better than much better than the result compared with the MIS CD technique. So to improve the fusion quality, we need to fulfill many conditions, such as adequate compression, minimal soft tissue damage, and preservation of the bony end plate. And we should have a lot of amount of bone graft with good quality and good quantity. And the cage material should be pro-fusion material, such as titanium. And the roll surface should fit the porosity of the cancerous bone. And the cage should be positioned as anteriorly as possible. And we should also have provide good mechanical conditions, such as a good footprint, stable fixation, and a radical disc clearance to accommodate a bigger cage or double cages or larger amount of bone graft. And with the UBE technique, we can fulfill all the conditions that we want. So that is why our fusion quality can be improved. So yes, we can improve the fusion quality and the clinical result using the biportal endoscopic system. Not because the biportal system can do that, because the biportal endoscopic system can fulfill our all requirement for a good bone quality fusion. Thank you. I think the UBE will be the future and the technique that can make the dreams come true. Thank you. 감사합니다.
Thank you so much for your wonderful lecture and for your live surgery demonstration as well. It was a wonderful opportunity for us. Next, we'll follow with the next class for us. So 네. 예, 들렸습니다. 네, 잠시만요. So now it's my pleasure to introduce our next speaker. Yeah, Dr. Ho Dong-hwa. He's the director of Harrison Spinardos Hospital in Cheongdam in Seoul. He's the vice president of the World UBE Society and one of the UBE leaders in the world. One of the greatest contributors to UBE development in the world through scientific papers, textbook author, and international speaks. It's a pleasure to have you today, Dr. Ho, and I would like you to give us our lecture today.
Thank you, Chairman. So unfortunately, I'm not the leader, just the experienced surgeons of the UBE. Yes, thank you. Anyway, I'll start. So today's my topic is the contralateral sublaminar approach using the bipolar UBE. Yes. So contralateral approach is a little familiar to the endoscopic spine surgeon. We frequently perform the contralateral sublaminar decompressions. Today's my topic, the sublaminar contralateral decompressions for the external root. So this is two routine incisions for the UB procedures. So based on the this midline of the base disc space, we have two portals, 1 centimeter superior and 1 centimeter inferior. So usually we made two portals like this. However, for the decompression of the foramens and the extending of root, we have to make two portals slightly lower comparing to the routine UV portal making portals. So this is the bone-up area for the contralateral sublaminar approach. We have to do a small size of the ipsilateral small laminotomy. Sometimes we have to do ipsilateral sublaminar bone drilling as well as the sublaminar bone drilling for the exposure of the contralateral side, foramens, and the extending lobe here, right? So this is the overview. So further, some doctors prefer the shaver drill like this. Some doctors prefer the small size or the waterproof high-speed drill. So for the contralateral sublaminar approaches, the waterproof high-speed drill is the better. I strongly recommend these kinds of the waterproof small thin drill system. So if we did a tilting of the two portals, we successfully approach for the contralateral side, as well as the traversing, as well as the external roots like this. Just tilting without any tilting of the patient's or table, we can easily access to the contralateral side, traversing root as well as the external root. So we have to find two surgical landmarks. Surgical landmark is very important for the successful and complete decompression of the contralateral side. First is contralateral ligament flavum. After removal of the ligament flavum, we have to find the foraminal ligament and SAP. So if we remove the partially remove of the SAP and the foraminal ligament, finally we can check and meet the contralateral action lobe here, like this. So this is another landmark. First is foraminal ligament. Second is SAP. So you can see the foraminal ligament. You can see the medial border and the tip of the SAP. So after removal of the SAP, partially, we can clearly expose of the contralateral foraminal ligament. We buckled or hypertrophied foraminal ligament. We meet the contralateral external lobe here. I carefully remove the contralateral foraminal ligament, hypertrophied. You don't need to hurry up, just achieve the contralateral decompressions slowly. We can finally meet the contralateral external lobe here. So the remnant of the foraminal ligament I remove. We finally meet the perineural fat and external lobe root, like this. So most important surgical landmark for the decompression of the contralateral external lobe, we have to find the SAP and foraminal ligament. After removal of the foraminal ligament, we can finally meet the contralateral external lobule here. So I will show my case. This female male patient presented with claudications, with the especially right leg pain. You can see the foraminal disc herniations as well as the lateral recess stenosis. So my plan is the unilateral laminotomy and bilateral decompressions, and then the rupture disc removal by the contralateral approaches. Now I will show my video. So left to right contralateral approaches. Firstly, I did a midline laminotomy at alpha S3 pose. The first step is very similar to the ULBD routine. So I did a left side laminotomy at the L34 area, and I did a contralateral sublaminar bone drillings and the partial removal of the sublaminar area, and hypertrophied contralateral ligament flap removed by using the Harrison punches, curettes, and pituitary forceps. Firstly, I decompressed contralateral lateral recess for the contralateral external traversing oblique decompressions. Firstly, I did, and then moved to the superiorly for the removal of the contralateral side rupture disc herniations around the contralateral external oblique. This point is the disc space. This is the axilla area. So you can see the rupture disc herniations easily. So first fragment I remove. So also I remove the rupture disc herniations. Maybe the external oblique is placed around here. So after the complete removal of the rupture disc herniation around the foramen, we can see the external oblique here. You can see the external oblique. And now I multiple fragment the disc herniations. And you can see the L3 oblique and external oblique here. So I completely remove the rupture disc particles using the contralateral approaches. So you can see the external oblique here and around the disc space here. And traversing oblique also I decompress. After surgery, you can see the post-operative MRI images showed complete removal of the rupture disc herniations as well as I did the central canal decompressions. S3 oblique extend axilla areas. And these patients presented severe post-leg pain. You can see there severe stenosis and posteriorly migrated rupture disc herniations. This patient, maybe 10 years ago, he received multi-level spinal fusions. However, this patient has a long history of the ischemic heart disease. So I can decide the fusion extension procedures. Also, this patient do not want fusion extensions. So I did ULB with the contralateral approaches. So right to left side approaches, I did L23 laminotomy, and you can see the severely hypertrophied ligament flavum. And then I move to the contralateral side. You can see the severely hypertrophied ligament flavum. And then you can see the sublaminar area. And then you can see the L3, L2. I expose of the proximal to distal end of the ligament flavum and then removal of the ligament flavum without any indentation of the dura. And then I remove to the foraminal ligament. You can see the posteriorly migrated disc material. The disc materials adhere with the dura. And then I firstly remove the posteriorly migrated disc material firstly. And you can, I did a sublaminar bone drilling for the complete exposure of the contralateral extended lobule. L2, you can see the severe adhesion and the posteriorly migrate ruptured disc particles. And then I'll remove. You can see the SAP and foraminal ligament. After removal of the foraminal ligament, finally we can meet the extended lobule here. This is the tip of the SAP. You can see the extended lobule here. Maybe the lower border of the pedicles. I completely remove the foraminal ruptured disc herniations. This is the disc space. You can see the L2, extended lobule, disc space. L2, disc space, and L3. And you can see the medial border of the pedicle. Move to there. So after the decompression, you can see the complete decompression of the central canal as well as the posteriorly migrated disc materials. So you can see there a complete removal of the foraminal ruptured disc herniations. So third case is a 44 years old male patient. This patient also presented bilateral leg pains. You can see there right side foraminal ruptured disc herniations and right side paracentral disc herniations. Also, this patient has right side ipsilateral left side down migrated disc herniations at the L5S1. This patient at L5S1, the three kinds of the disc pathology. What is your plan? Fusions or discectomies? So my decision is the ipsilateral and contralateral approach using the bipolar UBE. So firstly, I did removal of the ipsilateral disc and I moved to the contralateral side and contralateral paracentral disc removal. And finally, I moved to the extended lobule here area. So I finally removal of the foraminal rupture disc herniations. Firstly, I remove of the ipsilateral disc herniations through the axilla area and move to the contralateral side. Contralateral traversing lobule around rupture disc herniations around the contralateral traversing lobule, and then move to the superiorly, and then move to the contralateral foraminal rupture disc herniations like this. And after, are we just using one stone? I catch the three bird, central canals, ipsilateral and contralateral and contralaterals extended lobule. So after the surgery, so you can see the complete removal of the bilateral rupture disc herniations as well as foraminal rupture disc herniations. So the modifications of the contralateral approaches have very powerful energies. So sometimes the bleeding is some problem. However, we can, if you use the Elman type, the steering type of the RF, you can easily control the contralateral foramen. So around the extended lobule here is the bleeding control. I strongly recommend to use the Elman type RF like this. So the final case, sometimes I did combined approaches, contralateral sublaminar approaches with the ipsilateral paraspinal approaches. I will show. You can see the bilateral traversing lobule decompression and move to the superiorly. You can see the contralateral extended root. I put in the marked gel foam, put in the around the extended lobule axilla area, and then move to the contralateral side, ipsilateral side. I did the paraspinal approach for the complete decompressions of the extended lobule, and I find the marked gel foam piece through the ipsilateral paraspinal approach. And finally, I can complete decompression and long track decompression of the contralateral action of here. So in my opinion, so control approach is has advantage. We can clearly see the clearly and completely decompressions of the external lobe as well as foramen. Also, we can decompress transverse lobe ipsilateral and contralateral. So we can see the medial lower border of the pedicle. So we can minimize bone work. So we can minimize the facet joint injury. So it is a very good advantages. So optimal indication is the herniated disc and the foraminal stenosis and the cystic lesions. So the contralateral approaches using the bipolar has many benefits and many advantages. Thank you. Thank you for your attention.
Sure, Dr. Hall. I would actually like to ask one question to you regarding the contralateral sublaminar approach. For us that are starting our journey in UB world, what would you recommend as for our learning curve on how many cases should we have to perform successfully this technique?
Yes, so if we have a lot of case of the unilateral laminotomy and bilateral decompressions, if you can finish one level decompressions until the 1 hour, just start. Okay, so we're the extended ipsilateral laminotomy and sublaminar bone removal and find the foraminal ligament and the tip of the SAP and the partial removal of the tip of the SAP and foraminal ligament, we can finally can see the contralateral action oblit. So if we can one level decompression or one level discectomy until within the 1 hour, just try this. Okay.
Okay, thank you very much once again for your time, and we'll move right now for our next program. Our third and final surgery for the day, Dr. DJ Choi, one of the best instructors of biportal endoscopic spine surgery, will demonstrate us the treatment of two-level lumbar central canal stenosis. So we'll begin showing our case of our third and last surgery of the day. It's a 67 male patient with bilateral leg pain and low back pain. This patient has been suffering for these symptoms for 2 years. This patient showed on exam neurogenic claudication and decreased knee jerk. This patient has also received 3 years ago open lumbar microdiscectomy at the L4, L5 level. Here at images, we can see the stenosis at one side, at 3-4 level, and also left side compression, even after L4, L5 decompression at the right side. So for this patient, we have planned a ULBD at L3, L4, and laminectomy with UB at L4, L5. For this surgery, Dr. DJ Choi will demonstrate how to perform the lumbar treatment with UB technique. We'll be going in a few moments, so please stay tuned with us.
will show you how to enjoy the full content of Spine Academy. Log in at spineacademy.ac and enter our main homepage. We provide a wide variety of different content that you can enjoy. First, sign in at our Academy in the top corner of your browser. Click on Create a new account. Select a user ID and a password. Then, after confirming the terms of service, you are ready to access our content. In our education section, click on Educational VOD to access videos of our previous surgeries with comments done by our team. You can choose from a wide variety of different procedures performed by the Spine Academy experts. These videos contain edited footage of the surgeries, with comments, schemes, and tips and tricks on how to perform each procedure. This valuable information is not always available in textbooks. By clicking on Real Patient Case, you will have access to our library of cases based on real-life patients. Here, you can train your decision-making and follow the rationale of our team in deciding the treatment options of our patients. Decision-making is a critical step for a good outcome of any surgery. The step-by-step section grants you access to our variety of step-by-step guides on how to perform different procedures. Through videos, we provide a detailed step-by-step guide on how to perform each procedure, highlighting the key parts that you should remember when treating your own patients. Our Full Surgery tab will give you access to our library of full length of the surgeries, from skin to skin. See the real time that procedures took to be performed, and follow the retransmission of some of our live surgeries. The Conference tab will give you access to previous content from our courses and lectures. Explore and enjoy the vast knowledge of spine we share here at Spine Academy.
This is L34 central stenosis for 5 lateral stenosis left side, and the right side is already performed the laminectomy 5 years ago. So there's a low lamina state. So my portal is a little bit lower than the ordinary UB. So I focused on the interlaminar space rather than the disc space. So I pushing and touching the spinous process, and I make 2 portals as close to the midline as close to the spinous process base, and this is the interlaminar space, not a disc space, and the upper margin and the lower margin. 2 portals are located at 2 finger breadth, and the 4-5 2 portals, but the low portal of the 3 and upper portal at 3 L45 is very closed, so I made it one a little bit lower and made it 1. Okay, so I made it 1, 2, 3 portals. So if there is a 2 levels, I started from the low level first, and I make a new scoping portal in the L34. I can choose the best place for the scoping, but in this case L45 is a revision case, so L45 maybe there is addition. So in this case I performed L34 first. 약간 뿌연데. So 안에서 한번 닦아봐 주시고요. 안 되면은 스콥 So I make a 2 skin incision 1 centimeter apart, and the water is trapped by the subcutaneous fascia, not by the muscles. So you should excise the subcutaneous fascia clockwise direction. Then the fascia will be open wider. And I just make a just skin incision, and using a muscle dilator I put it through the scoping portal first and trying to landing on the interlaminar space, and use the detaching the muscles from the interlaminar space and trying to detach the basal muscles from the interlaminar space, and rotating the dilator and release the fascia, and the water comes out very fluently. And from the lower working portal I put it the dilator and try to release the fascia. Because of the previous surgery, in a way there must be a scar tissue. It is very tight. So after that I can put it the scope here. Okay, 이제 나가셔도 됩니다. 고맙습니다. 네, 한번 열어봐. 이거 열어봐. The scope is a little bit blurred and hazy. There's a haziness on the screen, so we should check the scope. 좋아진 것 같은데. Still fog. We should, I'm sorry, we should wait a little bit. The scope looks a little foggy, so we should change the scope. So let's talking about the portals. When there are many types of portals, but I use a little bit lower portal. The orthodox UV portal is located in just the medial side of the pedicle and landing on the lamina. Those are surface because we have to use a bar, so the scope should be located somewhere proximally, and the bar is coming out and landing on the lamina, bony surface, and from that point we're drilling down and make a space. But when you use a low portal, we can landing on the interlaminar space rather than the lamina dorsal surface. Then the only soft tissue, when the soft tissue in the interlaminar space is removed, then we can get a space easily. So always I'm trying to make a portal a little lower in the interlaminar space rather than the dorsal lamina. 이거는 저것 때문이라 카메라 이것 때문 아닌가요? 라인 한 번만 꼈다. 오케이. 이건 라인 문제인 것 같아요. 네. 네. 요거는 안 되니? 첫 번째 거예요. 다시 한번. 저는 안 되고 아까는 요게 아까는 요게 더 좋았던 것 같아요. 그 다음에 마킹 펜 있나요? 예. So we have to wait for we need the time for changing the scope. So I just explained where the bleeding comes out in posterior approach. This is a lamina and its mid portion, and maybe around this there is a transverse process, and from the lumbar artery, segment artery is branched and 5 millimeters laterally, and from the distal from the proximal margin of the TP 5 millimeters. So from this there is a lumbar artery and segmental artery is the branches, and there are 4 branches. So one is coming through the isthmic portion, one is coming and landing on the lamina proximally. So when you put the scope, the first bleeding comes out the left 9 o'clock direction on the screen. There is one on the branches, and the other branch is coming over the lamina, and this branch is covered by the muscle, so the 7 o'clock on the muscle, and the other branch is the inferior articular artery, runs downward and coming up through the isthmus and through the facet joint. So there is a 9 o'clock left side, a 7 o'clock muscle, and 5 o'clock direction around the facet joint. So 3 main bleedings coming out in posterior approach. So when you put the scope and the bleeding comes out and we cannot differentiate any structures, then you should coagulate the left 9 o'clock direction. Then you can make the surgical field clean in half of the screen. And the 7 o'clock and 5 o'clock direction, you can coagulate that, then you can make the surgical field clean. Now we are ready. Thank you for waiting for me. 저거 하나 주실래요? 꺼지 하나. 됐고요. 물 들어오나요? 여기. Okay. Put the scope. After dissection, the hematoma is still left in the interlaminar space, and so put the scope and shake it back and forth, and the hematoma goes out, and then we can see the space clearly. You can see that the white bundle is a musculotendinous bundle of the deep rotator muscle. It is attaching the lamina distal portion. So when you see such kind of fibers, then you should jump over the musculotendinous fiber. Then you are landing. You can landing on the interlaminar space shape. So after that, you can put it. 레스 한 번 더 주실래? Because of the previous surgeries, the scar tissue is there, so I just cut it, the fascia, and okay, the water comes out very well. And put the scope and jump over the musculotendinous fiber. This is a reference anatomy. This white bundle is a musculotendinous bundle of the deep rotator muscle. So jump over the musculotendinous bundle, and then we can safely landing on the interlaminar space. So it is interlaminar space, so we can easily get the base camp, and using a shaver. Shavering of the rugged, detached deep muscles is much faster than the radio frequency to eliminate the deep muscle fibers. So the screen becomes red. We call it red screen. Okay? Red screen. Where the bleeding comes out, there are 3 points. If the screen is red and we cannot get the orientation and we cannot get any depth, any structures, then please coagulate the left 9 o'clock direction first. On 한번 해주세요. 예, 케어 한번 봐주실래요? 예, left 9 o'clock on. Okay, on. 짧게요. On. Okay, left 9 o'clock direction. On. Okay, after 7 o'clock muscles on. Okay, on, and the corner bleeding 5 o'clock direction. So this final one has a 3-headed dragon. So put this area corner is a facet distal portion. Put this portion and you just step backside like a moonwalk of the Michael Jackson. So put this area, bleeding area, foot scope, and back walk is back step on. And left side on, 계속 밟으세요. Your right side and muscular area, 3 points. 네, 계속 밟으세요. 살짝 밟으시면 돼요. So the 3-headed dragons are captured by this radio frequency. So the 3 points are always there as a heavy bleeding. On. Okay, after that, the surgical field becomes clean. Left 9 o'clock, 7 o'clock, and 5 o'clock around the facet, and this vessel, this vessel coming from the branches of the main branches of the inferior articular. 계속 오십 밟으세요. 예. So if you control the 3 bleedings, and you can keep the surgical field clean. So you can get the base scan. And this white fiber is another reference and the puree. It is interspinous ligament. So this is a dorsal lamina and medial surface is the axillary portion of the interspinous ligament. And this is head portion is attached to spinous process base, and this is axillary portion, and this is tail portion attached to the medial surface of the upper lamina. So the axillary portion is the very weakest point. Thus the scratch of the distal lamina and the axillary portion, and the superficial ligament flavum is detached, and this is tail. Punchy thumb. And after that, using Carrison punch, 3 detached shape or detach the tail portion, and already the superficial layer is elevated. After that, using this gap, I put it, did you see that? I put it, the shaver, and eliminate the superficial layer of the ligament flavum and interspinous ligament. Then you can see the deep layer of the ligament flavum. Why we should differentiate it and eliminate it separately, the ligament flavum, superficial one and deep one. because after removing the superficial layer of the lymph flabum, we can see the bony margins clearly. Okay, after phlebotomy, using a shaver, the peripheral tissue, okay, are shrinkaged using a radio frequency using a plasma. Using a plasma, we can shrinkage the peripheral tissue and we can see the bony margins more clearly. Okay, so, okay, okay. The radio frequency is a plasma. So when you try to coagulate the bleedings, then you compress the area is a bleeding control. But when you shrinkage the soft tissue, don't push the area, just using a plasma and don't touch the soft tissue, and the plasma shrinkage the soft tissue. So osteotom. Now we can see the medial surface of the lamina, dorsal surface of the lamina, and the spinous process. These are, and spinous process proximally is not very little showing. So from the medial part, we should resect the medial surface of the lamina. Tok tok. Tap tap in Korean. Tok tok. So I use a tok tok. Neocortex, go. Neocortex, go. Neocortex only, go. Go. Yeah. Coming back again, go. Far cortex, go. Go. After making a neocortex fracture line, the fragment is broken safely. If you try to do near to far at one step, then the crack is happen and it goes the wrong way, and the subtotal laminectomy can be happen. Punch. So after resecting the medial surface of the lamina, we can remove that. 이거 펀치 3mm인가요? 조금 커 보여서. 오케이. K 한 번 더 주시고요. The upper lamina is not a pathology. The lower lamina is a pathology, can compress the nerve root or dura. Upper lamina is just covering your eyes. So the purpose of the upper laminectomy is not the compression. The purpose of the laminectomy is to put the scope and you can see inside, and the laminectomy is enough. So when you put the scope and you can see deeper inside, then the laminectomy is done. Very little laminectomy is necessary in performing the decompression surgery. Okay. So distally, how much laminectomy should be done? 3 millimeters overlapping curate. 3 millimeters overlapping area should be removed, should be exposed after a laminectomy. So after superficial phlebotomy, punch. 조금 작은 거 있네요. 아까 거보다 조금 작은 거. Okay. Okay. After removing that, this is this part curate. This is part of the lower lamina, and the curate is 3 millimeters. So 3 millimeters should be exposed, because after the 3 millimeters lateral side is the medial side of the pedicle. So 3 millimeters resection is enough, and is overlap is a limited portion with osteotom. So using chisel once more. Cool. A little bit resection is necessary. Cool. Coming back again. Cool. Cool. Okay. Cool. Okay. Punch. So now this part is the 3 millimeters. This lamina is exposed. So after that, approximately how much laminectomy is needed? The SAP, superior article process of the lower lamina, we should see that. Okay, 한번 더 주시고요. So on 페리토 치즈 안녕하세요 김재우 씨. 네. So when you put 큐렉 한 번만 더 scope. When you put the scope, the SAP tip is not exposed fully yet, so we need to excise this area. 안녕하세요 씨. This is a pedicle chisel, anteriorly 45-degree bending chisel. Using that, we can expose the SAP tip. Cool. 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 Okay. Cool. 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 예, 업바이트 작은 거 하고 보낙스 조금 준비해주시면 되고요. After resecting the ventral margin, some part of the ventral portion of the upper lamina, after removing the bony particles, bony fragment, and from the cancellous portion there is bleeding. So using a bone wax, sealing this 앞쪽으로 이렇게 해주시면 돼요. Using a bone wax, we can seal this cancellous portion instantly. 케어 한번 주시고 큰 거. The peripheral tissue covers your view and annoying frequently, bothering you frequently. So after that, we can see, we can see the SAP tip. That is the end point of the applyminectomy. Distally 3 millimeters, proximally SAP tip is exposed, then the applyminectomy is enough. Very, very little. We should preserve the lamina dimension, the lamina volume as much as possible because it's a decompression surgery, so we should protect the structures as much as possible. Sometimes the bleeding comes from the cancellous portion or sometimes the cortical portion, so the cancellous bleeding can be sealed with the bone wax and the cortical bleeding can be controlled with the compression, the bleeding focus. Instantly we can control them. Okay. Outside. So it's a bilateral decompression. So the diameter of the scope sheath is 8 and the instrument is roughly 5. So at least the 13 millimeters of the mid space is needed when you try to put the scope and the instrument simultaneously. So we make 15 in the middle, from the spinous proximal to this. We make to 15 is around the 10. So after that, and the ligament flavum deep layer is the thinning, and the capillary is coming out. Then you just it's okay. You think that the ligament flavum is left only less than 1 millimeters. The capillary is coming out, then the thin layer of deep ligament flavum is left only. Right? So don't detach the ligament flavum first, because if the ligament flavum, the layer is removed and the after bleeding is coming out, and the after bleeding frequently bothers your procedures. On, okay, on, okay. So after that, we should go to the contralateral side after decompression surgery. After decompression, coming back again and decompress the lower portion. This is distal spinous process. Climbing up the mountain and from the top, run down to the base and cut this midline of the ligament flavum. Then you can differentiate the superficial and deep layer. Climbing up the mountain of the spinous process and the you should touch the bony surface, this area of the opposite side, and run down to the base and cut it, this area. Then the ligament flavum is divided, superficial and deep, and the medial surface of the contralateral side is exposed. Shaver. And using a shaver, you can clean up the superficial layer of the ligament flavum, and you can expose the medial surface of the upper lamina. Okay. Then we can see the bony surface clearly. Exhale. Okay. On. The lamina is hypertrophied, so medially there is a very little space. So the instrument is blocked by the spinous process. So when I try to put some instrument to the opposite side, because of the spinous process, high mountain will still come. We cannot put the instrument to the contralateral side. So we should hide down from the base. So the width of the chisel is 5, and 5, so it's 10, and we need 15. So this one we should remove that before decompressing the contralateral, decompression to the contralateral side. Go, take it, go. Okay, go. Okay. After removing the spinous process space, this portion was pitched. Then we can remove the spinous process space and this central canal, the midline of the interlaminar space becomes 15. Then it's very wide, and any instrument can access to the opposite side. And and using, but we cannot see clearly the joint margin. So from this point, detaching the ligament flavum once more, deep for superficial portion of the deep layer, and detaching, and the superficial layer of the deep ligament flavum is detached. Pituitary. Still, there is a ligament flavum deep layer, so there's little after bleeding. So the surgical field is clean. So please preserve the deep layer until finishing the bony procedures. Cue that. Contralateral side, deep layer, just sliding and gently dividing the ligament flavum, and after that we can see the ventral margin of the upper lamina. Yeah, punch. And after removing that, we can see the ventral margin of the upper lamina on the contralateral side. So we'll still come straight. So the upper laminectomy. In the ipsilateral side, we started the dorsal medial is a high ridge. From this point we cut it, but the high ridge is over there, but we sacrifice from this point. You should resect it. You will resect it the half of the upper lamina. So from the bottom, only one width of the chisel, 2 or 3 millimeters. 2 or 3 millimeters resection is enough to see the lower lamina. Upper lamina is not a pathology. Lower lamina is pathology. Then how much the lower lamina should be excised? 3 millimeters medial side, because what is the meaning of the 3 millimeters? 3 millimeters is a lower lamina hook, medial groin from the medial margin of the pedicle. So 3 millimeters overlapping, exposing the lower lamina is enough. Okay, this is the part. And proximally, we should also expose the SAP tip. Okay, tail. On. Shrinkage the peripheral tissue to see the bony margin clearly. On. Okay, on. Okay, accurate. Then this is the distal part, and the 3 millimeters. Okay, expose. Okay, and proximally, and the SAP tip should be exposed, but not yet. Pedicle pedicle chisel 주시고요. anterior bending. 네. Using curved, using a curved chisel, we can access the ventral part of the upper lamina. So from the bottom, 2 millimeters resection. Go. 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 Yeah, that's enough to see exposing the SAP tip. If you want to see the contralateral foramen from the bottom, 2 millimeters resection. Once more, gives a view to the foramen directly, and you can expose the exiting root. So then we can access to the foramen upright. In this case, there is no foraminal census, only the L34 right side. There is a foraminal side, a little protruded disc, so we should check the foramen right side, disc state, and the foramen condition. Okay, then the upper laminectomy is done. Still, we should preserve the deep layer of the ligament flavum. Now, we should decompress and contralateral side. After decompression, when we decompression the ipsilateral side, after bleeding comes down and the surgical field it becomes turbid. So please keep this ipsilateral side and access to the contralateral side first. So when the SAP tip is there, just underneath, there is a disc space. There is nothing, only disc, so it is a safe area. When you put any instrument, this portion first is just over the root. Then you can compress, you can squeeze the nerve root. Still is a stent condition, right? So the underneath the SAP disc space is a safe region to detach the deep layer of ligament flavum. 2mm. Still a little bit narrow, so I try to trimming of the margin of the upper lamina a little bit narrow. So okay, and after that, put the 2mm, 3mm carriage punch is too big, and resect. Make a notch of the SAP tip. Okay, and the hockey, there is a notch, and yeah, you 왼쪽 오른쪽 chisel, yeah, and put it the hockey chisel, and the curved region can be inserted underneath the upper lamina, so it's safe. When you put it the straight chisel, then you can injure the root. So we pose it the chisel laterally safely and go. Cut the SAP tip. Go. 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 You can feel it broken down, the SAP tip. Just the neocortex breakage and the far cortex broken with the crack. Curette. Maximus 준비해 주시고. Using a curette. The function of the curette is hooking. The real function of the curette, which is different from the other device, is a hooking. So we can remove the deep fragment located in the deep portion. The SAP tip is attached by the foraminal ligament flavum, so it is not easily removed. So using a curette, hooking the fragment, release the foraminal ligament flavum, and we can remove that. Maximus. This is a foraminal lesion and foraminal ligament flavum. This is a 5mm curette, which call name is Maximus, because they have a strong power to attach the foraminal ligament flavum. So after removing that, we can detach the foraminal ligament flavum well successfully. So the foraminal area is decompressed. So after that, coming back again. Now this is the time for the ipsilateral decompression. Okay, show that. From this point, we can proving touching underneath the distal lamina, which there could be a adhesion. So using a curette, detaching this area clearly, and after that, osteotomy straight, and using a straight chisel is a 5, so only two or three with this is enough. But don't break it too much; it's very hard. Okay, so Okay. Okay. So after that, breaking the vertical margin of the distal lamina, removing some particles, and epidural bleeding start to coming out, and on, 이거 안 됩니다. 반대쪽 바꿔서 눌러보실래요? on. 케어를 바꿔보세요. 예. 다시. on. Okay. On. Yeah. The assistant is first time live surgery, so the assistant is very nervous. Please excuse that. Okay. Good. And the punchy 거꾸로. punchy. So distally. For distal laminectomy, always very curious about the end point. Distally, which is the end point? So this is a cortical margin, and from this cortical margin, the cortical could be a could be a hypertrophy or sometimes a normal cortical portion. But anyway, we should expose the nerve root. So distally, the cancellous portion should be exposed after corticotomy. Cancellous portion should be exposed. 3mm. 다 올려놓고 쓰셔도 되나요? 예, 상에다 다 올려놓고 쓰셔도 될까요? 예. 예. Okay. Still cortical bone, and the cancellosers start to be exposed. And okay, distally, cancellous portion start to exposed. Okay. And laterally, we have to touch the medial surface of the pedicle. 이미리 주실 수 있으세요? Okay. punch 2mm, and proximally a little bit. I can touch the medial surface of the lamina, the pedicle medial border. So make a notch. Make a notch. Okay, hockey left. After that, so the after bleeding from this point is coming out, and we cannot differentiate it. So if you have a deafness, feeling of feeling of the deafness, feeling of the deafness, you can use the radio frequency. But it is the first 1 or 2 times, so you have no experience of, and you cannot feel it, the deafness. There is many vessel branches, so you cannot feel the deafness. You use a bone wax and sealing this corner like this once, then you can get immediately you can get the clear view. 그다음에 chisel 왼쪽. So you can use the hockey chisel left side. Because of the very narrow space that the Carrison punch cannot inside pose this approximately. So using a curved one chisel, proximal SAPT can be broken. Near cortex breakage, far cortex can be broken with the cracking. Maximus. After that, using a bigger curette, put it underneath the fragment and lift it up gently, gently. The big curette is more safe. The big curette has a big buttock and it pushes away the dura, the opposite side, and the blade is located laterally, and the buttocks located in the medially, and the fragment can be safely removed. The SF tip is attached by the foraminal ligament flavum, so it is not easily removed. So moving this fragment in the safe area. After that, picture coming up. Using a pituitary, we can safely remove the fragment. Okay. So this is a stenosis, so the ligament flavum is a hypertrophied state. So just the medial side of the border of the pedicle. The after bleeding comes out. There is a main branches. And this is a discal space level. One, okay, maximus. One. Clarity. Okay. One. Okay. One. Okay. Maximus. This is a maximus, 5 mm curette is a bigger one, and put it underneath the ligament flavum and lift it up, gently lift it up. There could be adhesion, so we should gently lift it up, and full layer of ligament flavum can be removed. It's the same as a envelope flavectomy, but we can access underneath the ligament, underneath the sublaminar area using a chisel and curette. Okay, that's maximus. And this area, there is a big, bony beak. There's a foraminal ligament flavum and cleansing up. Okay, punches on. Okay. But sometimes in degenerative lysis or fascial hypertrophy, the sublaminar area, there could be a muscle hump protrusion ventrally. So at that time we can use such kind of curved chisel, and ventral will be accessed, and ventral sublaminar area, and we can cut it the ventral surface, bony hump, and we can get a more interlaminar space free of bite. So without touching without resection of the upper lamina, we can decompress the sublaminar area fully. Is a foraminal ligament flavum. This area of the ligament flavum medial side is running to the foramen, so using a bigger curette we can remove the foraminal ligament flavum also. So the ipsilateral decompression is done. Now we are moving to the opposite side. Curette. So in the middle, when you put some instrument in the middle, we should be careful. There are 3 layers: deep layer of ligament flavum, epidural fat, and dura. Because of the cell line pressure of the dura lateral side, the central is folded here. So under the fat bush, there is a dura central folding, so we should be careful. So when you put any instrument under the epidural fat, there is a dura tear. So when you're crossing to the opposite side, lift it up. This is a safe space between the ligament flavum and epidural fat. So under the epidural fat, there is a lion waiting for you to swallow you. So don't put any instrument under the epidural fat. Just gently moving under the ligament flavum over the epidural fat. That is safe way. Maximus. After removing some part of the ligament flavum, then we can check the safe margin. After that, putting some bigger curette underneath the ligament flavum, just scratch out underneath the sublaminar area. Then the envelope total flavectomy can be done. Upright. This is upper side. Now the ipsilateral side, distal and foramen SAPT is fully removed, and the contralateral side only SAPT is removed. So distal laminectomy on the contralateral side is not yet done, the maximus, and proximally there is still ligament flavum. Using a maximus 5 millimeters curette, you just scratch out hidden underneath the ligament flavum. Then we can remove that, and dura can be inflated and expanded fully from proximal to distal area. When you try to see the exiting root, you just exit in there, and you can see the foramen, because we already excised 2 millimeters more in the proximal portion. Long term. This is a disc space, and you should remember this reddish fibers is a basal bundle underneath the nerve root axilla portion. Okay. Upright. So after removing that, we can access to the foramen, and we can see the exiting root over there, but there is no foraminal stenosis severely, and this is the epidural axilla fat. For the migration disc, we should access it like this, contralateral approach, and after removing the axilla fat, we can see the margins of the dura and the nerve root, and we should remove the fragment. The tail of the migration disc is located here, but in this case, no lung to them. And if there is a deeply, there is a SAPT is here, hypertrophy, and any instrument can access there, put the king curette and put it under the SAPT and remove the scratch the area, and the foramen SAPT and the foraminal ligament can be removed fully well, and we can fully decompress the foramen, and then we can inspect the exiting root over there. It's a foraminal ligament flavum. Underneath there must be a nerve root. 다시 long-term. Because of the several times injection, this foraminal ligament flavum is thickened, so I remove that. Okay, and the contralateral side, the distal laminectomy is left, and the transverse root should be clearly seen, and the bony scar 케어 잡은 거, and on, and this lamina is covered this part of the nerve, bony cover the traversing root, so we should do the distal laminectomy on. Okay, on. Okay, what's the outcome? Yeah, from this portion, go, very hard, go. Is a spinous process base, pitch. 다시 pituitary. Okay, 다시. Using a straight chisel. So after the spinous process space, distal spinous process space resection, instrument can access to the opposite side, even in the distal part, the punchy E. So using this, that we can get some clear space, and we can put it instrument underneath the distal lamina, or we can excise the distal lamina spur. I can touch the pedicle medial margin. Okay. And the traversing root is start coming out. Okay, it's permanently accurate. So there is a vessel, is some other digits. So this is a dura, and this is a traversing root, and this L34. So the nerve root is not clearly seen. It is located underneath this lamina. It's not L45. So the nerve root is not seen yet. It's L34. So anyway, this portion a little bit narrow. 자, 펀치 한번 주시고요. 그 다음에 다시 페디클 치즈를 주시고. You can do this laminectomy more, or anyway, the pathology is just that portion compressing the nerve root, this portion. So we don't need to excise fully the distal lamina. We pose it the pedicle chisel. Go. Okay. After that, removing the underneath the distal surface, and we can make a little bit more wider space. Then the nerve root. I think the nerve root becomes more free. Okay. Curette. Yeah, only a small bony fragment is left. So using a curette, hooking the fragment from the corner. Okay, upright. 젤폼 조그만 거 있으세요? 1mm 곱하기 1mm, 1mm 곱하기 1mm 하나, 2mm 곱하기 2mm 조그맣게만 하나. So this is a distal corner. If lucky, hair 작은 거. A small hair can be accessed there. 조그맣게만 잘라주세요. 5mm보다 작게. 네, 꽉 눌러주시면 됩니다. on, 짧게, on. The vessels are located just the medial side, of the on. Yeah, but on small branches still. Yeah, tell me, bleeding comes out. Then you can put it the gel foam, very small size. Pituitary pingo. Yeah, free, covering this pingo. Yeah. You can put it the gel foam, very small, 2mm square, and just put it the corner. Then it will successfully control the bleeding. So the 3-4 decompression is fully done underneath from the proximal to distal foramen. It's okay. Let's move to the 4-5. Dilator. The right side is also already decompression state. We should prepare some scarring, because in previous surgery is open surgery. So we strongly scratched out the interlaminar space scar tissue. If lucky, there is no scar. Okay, and the distal, and the proximal one is a little bit higher, becomes a higher portal. And put the scope and shaking back and forth to evacuate the hematoma in the interlaminar space, and the structures is coming out in the shaver. And putting the shaver and remove the floating soft tissue. Suction을 되는구나. So after that, we can remove the soft tissue. Oh, this is very lucky. There is very little scar tissue. It's okay. So is the interlaminar space. This part is interspinous ligament and medial side. Okay. When the putoscope, the bleeding comes out, you should clog the 3 portion. In the left 9 o'clock direction first, on, left 9 o'clock first, and the 7 o'clock under the muscle, on, and this the corner bleeding. putting this area corner, and you should need the moonwalk of Michael Jackson and coming back on, and the left side and the right side and the back side. The three-headed dragons are there. The vessels, 3 branches, always on, and shrinkage the peripheral tissue, and we can get the clear surgical field. Okay, it's a base camp. Sure, is interspinous ligament. The axial portion is the weakest point, so scratch the distal margin to see the bony surface and get the orientation well, and detaching the superficial layer of ligament flavum from the deep layer and punch. And after removing that, okay, its lateral half is removed, correct? And the capillary of the ligament flavum is start to coming out. That means only 1 millimeter is left. So the ventral hump, ventral side, the thickened portion is scratched out, punchy, and then we can see the bony margins clearly well in the upper lamina. Now we are ready to do upper laminectomy. Osteotomy. Using a straight osteotomy it is a medial surface, dorsal surface. It is a high reach, just the medial side high reach at the distal portion. Pose it the straight chisel, neocortex, neocortex, neocortex. We make a way first, then coming back again, far cortex, very hard, okay, far cortex, then we make a fragment incision along the way we want. Punch. If you do near to far, it's just one step, then there's a wrong crack will be happen, and the fragment, the upper lamina is broken subtotally half, so it is dangerous. So make a small near cortex first, near first, and far later. To that also, and distally 3 millimeters of the low lamina. One curette is 3 millimeters, so 3 millimeters is open, and the upper laminectomy is not. Normal right section is needed. Proximally, SAP tip should be exposed, and it's very lucky, nearly exposed fully well. But underneath it, there could be a big spur. So 안녕하세요. Using a pedicle chisel, curved pedicle chisel, we can access the ventral directly from the bottom. 2 millimeter resection can eliminate the ventral hump, ischemic spur, and we can get the spinal canal a little bit wider. So in grade 1 spondylolisthesis, we can compensate it, the decrease the spinal canal due to the ventral slip, and it can compensate it at the spinal canal with us, and the dura can expand it fully, maximus. So the distally 3 millimeters proximally SAPTB exposed, then the upper laminectomy is done well, and that's enough. And okay, thank you. And the right side is already done of the open laminectomy, so we should be careful of the scar tissue. Anyway, it's very lucky. So scratch up, scratch up, scratch up. Okay, shave. Okay, the middle line opening of the ligament flavum. Okay, that curette. Using a curette, detach the ligament flavum from the lower lamina, and we are proving the undersurface of the lamina because we should expect any adhesions osteotomy. After that, using a straight chisel, breaking down 3 millimeters. Neocortex, neocortex, neocortex is enough. Far cortex is broken spontaneously. Okay, tissue. After removing the fragment, we can get a space to see the undersurface of the lamina. Then, using a 2 or 3 millimeters Carrison punch, we can do distal laminectomy. There's a free space, and we should move some medial laterally, and we should touch until we should touch the medial surface of the pedicle. Okay, to that. The cortical hypertrophy is there, so detaching the ligament flavel, we can see the undersurface of the distal lamina. Very hard, the cortical bone, so using a little bit bigger 3 millimeters Carrison punch, we can do laminectomy. So the very best point, very best point of the very strong point of this surgery is we can use any instrument which are used in open surgery. So we can do forceful handling of the bony structures. Yeah, cortical bone is very hypertrophied. Medially, not yet. I cannot touch. 벌려주시면 돼요. I can touch the medial surface. Not yet. There's a root, and the left side undersurface of the cortex is hypertrophied very much. Okay. Okay, now I can touch the medial surface of the pedicle. Okay, then we are moving to the proximally. Haki, 왼쪽. Haki, 왼쪽. So from this point, we make a notch for posing the haki. 좀 천천히 Okay, broken, cracking, well, maximus. And underneath the fragment, we can put it some bigger maximus, 5 millimeters curette, and lift it up. The big hypertrophied sclerotic bony low lamina spur. SAPT is removed in the safe area, and then we can remove the fragment. After that, using a maximus once more, maximus. Now we are gently put it in the underneath the ligament flavel and scratch down very proximal portion to scratch out the ligament flavel. Then we can do en bloc phlebectomy without full laminectomy of the upper lamina. Okay. 다시 왕큐렛. From the midline, we should be careful of the previous surgery scar. Is the upper side tissue. It's midline. Okay, curate. So after seeing that this is dura and this is a disc. Disc is a little protrusion and a floppy, a little bit extruded state, and dura is shifted in the medial side. This is a pedicle medial margin. 이렇게 작은 거. So after resecting the SAP, always the disc space is exposed well. So without root retraction, dural retraction, we can access to the disc space. And from this safe margin, safe area, from this area, we can do discectomy. On, Indian knife, on. Is already exposed and the annulus is a little bit tear over there. On. So the in the epidural space, always the bleeding comes from the segmental artery, foraminal, and suprapedicular artery is here. It's running. It's now running along the pedicular margin. So always the heavy bleeding comes from this corner, not this point. Always there's a heavy bleeding, then you should coagulate just beside the bone, pedicle. Then you can control the bleeding. Okay, Indian knife. And this is the Indian knife and the dissector, and besides the first layer of the annulus is a little bit harder. Don't remove the deep layer of the nucleus. Children, the extruded one is a pathology which compressing the nerve root or dura. So we should divide the layers of the annulus, and pathology is just located outside of this area, not deepest portion. So the nucleus is not a pathology. Only extruded hard annulus is a pathology. Okay, picture. It's not too much. Not too much. Just try to remove and check any fragment, compressing, pushing the dura. Okay, not too much. Okay, it's old. Okay, I'm having on. So after removing, this is not a big, huge disc protrusion extrusion. Anyway, we just incise the outer layer of the annulus. The deep layer is still preserved. So the only remove the superficial layer of the annulus can prevent the frequent recurrence of the disc herniation. Only extruded out, extruded one, we should check that and we should remove that. Okay, and the deep layer is still tight and solid and there's no pathology. Okay. So, we should check one. Once more, it's a hard disc, not a soft one. Upright. It's old calcified disc. It's okay. Okay, I'll have a look. So the cerebrectomy is a negative discectomy. Anyway, it's a hardened one and there's no fragment. Okay. So after the curette, the nerve is coming out well, and the opposite side is laminectomy. It's already previous surgery, so don't go there. It's okay. It's okay. It's okay. There is a free space. So L45, the compression is done. Thank you, everybody. It's finished. I will wrap up this surgery. Thank you. 피추 작은 거 한번 주시면.
I hope you guys enjoyed the final demonstration of live surgeries that we had today. Dr. DJ Choi masterfully showed how to perform the ULBD and how to approach the laminectomy from one side, having known that the contralateral side was already breached. We will now return with some of our final lectures. Dr. DJ Choi will teach us more about the paraspinal approach and the other pathologies that we might face when trying to approach it, and some of the reasons why when we try to do the foraminal decompression, we might not identify the correct pathology and might have some problem with these patients. In brief moments after he returned from the OR, we'll return with our final lecture. Today we are going to show you a step-by-step guide to perform the percutaneous epidural neuroplasty. By introducing a catheter into the anterior spinal canal, mechanical and chemical release of adhesions to neurostructures is performed. Following the 6 steps, you'll learn how to safely perform the pen. We would like to give special focus in some key points of this procedure, which are the safe needle insertion, the ventral positioning of the catheter, and the confirming of the root shadow. The materials needed will be the epidural kit, medications, and radiopacti. Step 1. Preparation. Position the patient in prone position exposing the sacral region. Get a good AP and lateral C-arm image, and then sterilize and drape the skin. Step 2. Local anesthesia. Use the left thumb to locate the sacral tubercle and feel the sacral hiatus. Insert the thin needle 1 cm caudal to the sacral hiatus and apply 2% lidocaine. Remember to use the thin needle for local anesthesia. With the tip of the needle first touch the bone and then slide it into the sacral hiatus. Memorize the angle of insertion of the needle as the stylet will enter in the same angulation. Step 3. Needle insertion. Nick the skin with the scalpel and pass the stylet inside. The stylet must first touch the bone and then its angle is adequately dropped to pass through the sacral hiatus. Remember to keep the tip of the needle to the ventral side. Once C-arm confirmation is done, we can then remove the stylet and advance 1 cm the cannula into the canal. Inject radiopac dye into the canal and confirm with C-arm image its spread. Step 4. Catheter insertion. Once correct position is obtained, it's time to pass the epidural catheter. 5 cc of local anesthetic can be applied to the canal once more. We can then advance the catheter carefully into the ventral epidural space, controlling it with our left hand. It is very important to keep the catheter in the ventral epidural space. This is done by initially positioning the catheter tip laterally and then advancing to the ventral position. Remind the patient that pain can be felt in this and the next step. The catheter position is confirmed with lateral C-arm. Here, there is one example of incorrect dorsally located catheter tip. Step 5. Treatment. Gently maneuver the catheter within the epidural space with the left hand and place it to the targeted position. Mechanical adhesiolysis is performed by moving the tip back and forth next to the adhesions. Next, place your left hand steadily in the handles to maintain position, remove the guide wire, close its opening, and use the medication opening to apply radiopac dye and confirm the nerve root shadow. In the following images, we show the shadows of the S1, L5, and L4 nerve roots to the right side and to the left side. Application of dye is followed by a forceful injection of saline and finally applying the medication with slight pressure. After sequential injections, the guide wire is reinserted and the other desired levels are targeted. And finally, step 6. Remove the catheter from the epidural space and its sheath from the sacral hiatus. Apply gentle pressure to the entry point and appropriate sterile dressing.
Thank you for joining me again, and let's start the principles of the transforaminal approach at the 2. Now, in this speech, I will focus on the L5S or foraminal stenosis. Due to the specific configuration of the L5S1, TP configuration is a little bit different from the other level, and because of the ALA, we should focus on the L5S1. Including me, many surgeons perform the transforaminal approach L5S1, but roughly 50% is good and 50% is not good. We should focus on why these things happen to the L5S1 transforaminal approach. One of the reasons is subpedal kinking. It is hidden in the paper. It is a hidden pathology. So SAP is a dynamic, one of the dynamic pathology. Sometimes it make a symptom, sometimes it does not, depending on the patient's posture. The subpedal kinking also is a dynamic factor. Sometimes it make a pain, and sometimes it looks good. It does not make a pain. So anyway, everybody knows that there is a subpedicular kinking. But what is the pedicular kinking? What is a radiology clue for suspecting the pedicular kinking? There's no document. So just in my experience, I just explain something. But it could be true in some aspect, but it could not. Anyway, until now, even the disc height collapsed, if the superior part, proximal part of the nerve root, there is a free space, that means a free space. Then there is no contacting surface, subpedicular area, and the root. It must be okay. But in some cases, it does not look so severe. Above the nerve root, there is no free space. And CT coronal view, because of the stress, TP isthmus junction, under surface of the isthmus and the SAP, the cortical bone is hypertrophied. Then the nerve root should run under the pedicle, but there is very little space. One of the reason is endoplate spur, and one of the reason is subpedicular cortical thickening. That the nerve root can be impinged under the subpedicular area. So we're checking the CT and MRI, and I try to checking this point, and there is I think that it looks a little narrow. Then I perform the subpedicular decompression using a pedicle chisel, anteriorly 45-degree bending chisel. Just try to resect the subpedicular area. Cortical thickening can be excised only. Yeah. Then anyway I can make more space, 1 or 2 millimeters more for the nerve root. Endoplate spur is also notorious for, and everybody knows that it could be a pathology. But which spur is a pathology, painful? Which spur is okay? There's no exact document on the paper, not yet. Endoplate spur is a little bit different from the disc rupture. The nerve root can be impinged, the pedicle, subpedicular area, and endoplate spur. And this section view, the transversely growing, the endoplate transverse growing, and the coronal view also the subpedicular area is narrow, and the axial view, the smooth round contour is gone, and the endoplate, the spur is growing and looks very rough and irregular space. Then we should suspect that. So the Sung-Soo Park, the Korean spine surgeon, categorized on the CT base, categorized the endoplate spur, morphological categorized. Normally there is a little protrusion, is normal, and a little short transverse protrusion is grade 2, and the foramen is very wide, so it is non-symptomatic. But transverse long, and the foraminal height more than 77 millimeters and less than 7 meters. The foramen height is at least 20, and the L5 exiting root occupancy is maximally 30%. So 20 multiplied to 30% means 6 millimeters. So at least the 6 millimeters should be preserved from less than 7 millimeters. 6 or 5, then you make a nerve root compression. So the transverse long with the foramen height less than the 7 millimeters and hooked up spur-like upward growing spur can irritate the nerve root, squeeze the nerve root. So it is a pathologic endoplated spur. When we perform the transforaminal approach, we can inspect in the decompressed nerve root. Those are half, but the nerve root is ventral half is still squeezed, so easily neglected even during the surgery. So when you check the CT and the session view, and the CT shows the long transverse foramen height less than 7 or a hooked up portion, definitely we should decompress the ventral half of the nerve root. That is endoplated spur. But the ipsilateral side accessing the lateral recess and foraminal area can be decompressed, and the surface of the nerve root can be excised, decompressed like a discectomy, but the extraforaminal area we cannot reach there because of the lamina. But the transforaminal approach or the contralateral approach, we can decompress the axial portion, lateral recess, and the foraminal portion underneath the nerve root and the extraforaminal area fully. So when the nerve in the actual view CT, the endoplated spur is long and wide, so at least the lateral recess foramen to extraforaminal area 15, then we choose the contralateral approach or the transforaminal approach. Ipsilateral accessing just stopped just in the middle side of the extraforaminal area, then the extraforaminal area and the place spur is still left. It can make a pain, it could make a pain, or sometimes if lucky there is no pain. Anyway, it's limited. So for the accessing, for the decompression and endoplate spur, we have to choose the approach. Frau syndrome is also hidden. We have a concept and we have eyes to read the CT or MRI, then we can suspect the Frau syndrome, but it's just normal eyes. We have no idea of what happened to the L5 extraforaminal area. Normally, conventionally, the Frau syndrome means a syndrome is syndrome, not a, there must be a pain. Something happened, but we don't catch it. What happened to that on the radiology clues? That is a syndrome. So the foramen outside, there is something happen, then we call it the Frau syndrome, conventionally. But as an endoscopic view, actually the foramen is SAP and the disc is a problem. Extraforaminal area is the foramen is wide and open, so the extraforaminal area pathology is the extraforaminal disc mostly only. And the Frau syndrome L5 is happened, the TP is TP a la junction. So we should differentiate the pathologies because extraforaminal area there is only disc problem, and the Frau area L5S1 is distal TP and a la junctional problem. It's a bony pathology. Why these things happen? Because the lumbosacral angle, TP is the angled ventral portion. Distal portion is angulated ventrally, so this distal TP ventral portion can touch, can squeeze the nerve root at the TP a la junction when the disc had collapse and disc extrusion and the ventral slip, elisthesis. Then the nerve root can be impinged this area. Why we call it distal TP? Because of the angulation, the whole area is not a pathology. Whole TP is not a pathology. Only distal or ventral area. Distal ventral area can compress the nerve root. It's just like a book edge. The book cover edge can compressing the nerve root. The dorsal surface it never touches this root. So we call it the L5 transverse process. L5 TP distal ventral DV spur. L5 TP DV spur. Surely we call it like that. So this is a distal surface, is a ventral protrusion, protrusive spur. So we after resecting this area and the nerve root is coming out. On the CT coronal view, mostly the Farrar syndrome happened in the coronal tilting area. So the right side, okay, always the left side is symptomatic area, and due to the ventral slip, TP is also prolapsed ventrally and along the ala, the axis. So we can classify it, we can staging the Farrar syndrome. When the disc is good, the TP is usually located neutrally on the line of the ala. Is stage 1 is normal, and the disc height is collapsed, no ventral slip is stage 2. Only the foramen height is narrow, and the Farrar syndrome could be okay. But there is a ventral slip, then the extraforaminal area definitely must be narrowed, and the nerve root can be impinged between the TP ala junction. So when the CT shows such kind of ventral slip and the spur long times, and then we should check the transforaminal area under the TP distal ventral area. Spur should be excised. So in the microscopic approach to solve the Farrar syndrome, they said that unroofing the nerve, unroofing this phrase extraforaminal area, so distal TP, subpedicular area, and SAP tip fully, and even along the ala portion. Unroofing, whole the bony structures can be decompressed to solve this problem. But I totally agree that, but the SAP, the lateral plan, should be preserved. So when you sacrifice to solve this problem, when you access into the transforaminal approach and excise the superior articular forceps fully, then the disc height is collapsing down, and the coronal tilting, the Farrar syndrome becomes aggravated, and the disc height collapse, and the LS1 root can be impinged under lateral recess if there is a lateral recess spur. So when you sacrifice the SAP lateral plan, SAP fully is such case of Samson and Delilah. So when you excise the lateral plan, when you hold any kind of transforaminal approach, then you collapse the whole nation, and you will also be dead. And the final one. So all day long, I focused on the foraminal decompression. Then always is happy, and always successful? No. In my case, only counted on L5 as only 60% is happy and 40% is not good, and then the more than 14% and need early revision cases. So sometimes good, sometimes bad. Why these things happen? We learned that if the disc height collapsed more than 50%, 80%, and no more collapse and no more progression and stabilized because of Kirkcuddy-Willis theory, the fascia is hypertrophied and disc is stabilized and calcified, and no more progression anymore, only stenosis is left. No. Is there any motion? We call it radiographic observation and instability, 4 millimeters anterior sleep and then 10 degree hypermotion. No, it's stabilized, fully decompressed, fully collapsed. Even the end plate is fractured because there is no disc. And the foraminal stenosis, so I decompressed the foramen. But even after though a few months later, the end plate fractured, stress fracture is progressed, and the foramen and the end plates collapse, and the foraminal stenosis happen again. Why these things happen? Because I sacrificed the SAP fully. Even without that, it is still progressed because even before the surgery, foraminal decompression, and the plate, there is a stress fracture, fatigue fracture, and the signal of the end plates already changed. That means still progressed the motion and instability. We call it clinically symptomatic instability. So it's never stabilized. So the buttock pain, radicular pain can be solved, but due to the buttock pain, the grandma cannot walk a longer distance, only 5 minutes walking and standing 5 minutes. Then they have to stop walking and have to sit down because of the buttock pain, referred pain. So actually, we just normally said that the ordinarily said that talking about the instability, that is an observational radiography instability, hypermotion, but the hypermotion happened in a very early stage of degeneration in the listhesis. So every review paper said that it happened in the very early stages. So when the degeneration is pressed down and the facet is stabilized and the motion is decreased, and there's no need of the fusion, only decompression needed. Every review paper said like that. But in clinical symptomatic instability, it happened in the last stage of degeneration. Such kind of degeneration never stopped the pain, never stopped the degeneration. The endoplate is maceration and collapsed. Both sides facet is prolapsed, then the kyphosis, the segmental kyphosis happened, and endoplate is maceration happened. It is clinically symptomatic instability. And the canal is narrowed, central canal is very narrowed. But mostly in the list, this is grade 1, one side coronal segmental scoliosis and segment collapsing and discus collapse, and the plate is color, and there was a signal is changed. There's still pain. Then we need a fusion. So it's my clinical, very private, but very private indication of the fusion surgery. So the endoplate color, discoid collapse mode 50 and 80, and the endoplate and the bony signals changed totally, and the foraminal snares happened, and I recommended the fusion. So to restore the bony, disc height and the screw fixation, it's okay. We can solve one problem. But the problem is, if you perform the fusion surgery in MIS technique, it's okay. But when you try the endoscopic surgery, the learning curve is very long, and there are still hidden potential complications. And the TLIF is also, when you put the cage on one side, you just open both sides of the fastener, release the fastener, and the cage is inserted safely, it's okay. But in these days, everybody performed the minimal invasive MIS, the TLIF. One side facet, one side foramen is open, just to try to put it in the bigger one, bigger cage. Then the other side is the endoplate is broken. So if the cage is not posted yet properly, then the cage early prolapsed, and the cage is inserted forcefully. The endoplate is fractured and is still left in the malunion, and it compresses, irritates the nerve root. And in these days, the segmental loaders is one level. Segmental loaders is also very important to prevent the ASD. But after collapsing of 2 or 3 millimeters of the endoplate, the segmental loaders is gone away. And lately, if there is non-union, the endoplate collapses more and more and more, and the posteriorly endoplate fractured fragment irritated nerve root, and slip away, and the metal loosening and non-union. Big disaster. But big surgery is needed. So the most common etiology of cage-related TLIF is cage itself. So how about the endoscopic fusion rate? Is very nice. Everybody said that endoplate preparation and bone graft and everything is okay. Everything. But the problem is the technique is difficult. Only decompression need more than 100 cases, and for the fusion, the more than 30 or 40 cases and 70 cases of the fusion, then 1 or 2 or 3 years is needed. Then every patient visits you. You are just starting endoscopic surgery. Then all the patients are in the danger of the learning curve of yours. And the operating time is much longer than the open TLIF. And still, in a very narrow space, we handle the big device and the big cage, so there is a high risk of dura tear and root injury. So we should learn the portals, the water control and triangulation, and sublaminar decompression and chisel ball technique and bleeding control, and we should understand regional anatomy, and we choose the approaches, and if there is dura tear, we should control the dura management. So many things we should learn there before starting the TLIF, endoscopic TLIF. If there is one miss, then all the fusion, the result of the clinical result of the fusion is not good. So we have a negotiation. We have a negotiation tricks before you are being very excellent to endoscopic fusion surgeon. So I performed a little cases. Is my personal experience. There is a facet fusion the PLF, you know, the posterolateral fusion. We just believe that PLF, it's not that bad. It's not bad. It's not a cage, but it's not bad. But the facet fusion rate is much higher than the posterolateral fusion, and we don't need to wider muscle dilation, muscle injury, rather than the posterolateral fusion. And there are several reports of the facet fusion, and the fusion rate is very high because we just fuse only small bone with the little gap. So only one side, even one side, one or two sides of the facet fusion is concluded, is decided as a fusion. So using scope, we can see the facet and eliminate the decortication and denudation of the facet and put it the bone graft. And with the small bone graft, we can fuse the facet. The base of the fusion is the 50 millimeters long and 10 millimeters wide. It's 18% of in contrary to the disc space vertebral body. The 80% is the same surface of the 80% of the vertebral body. So using a bar in transforaminal approach. In transforaminal approach, this angle is similar, very exactly same, parallel to the facet joint, and so we can easily access to the facet very vertically, and using a 2 or 3 millimeters burr, we can decompress denudation and decortication of the facet. And I need a very early fusion, so I tried the BMP with the TCP and the base. And then using on the bone, orthobone is harvested from the spinous pores. Always we have to resect this area and put it very small bone chip after that. So in degenerative scoliosis is 2, 3, and just the left side is a problem. So I just put it one side of the pedicle screw. Facet is both sides is alive, so the unilateral fixation is okay, and in unilateral pedicle fixation is shows the long-term result of the lower ASD than the bilateral pedicle screw fixation. And the 4-5, central and foraminal stenosis, decompression both sides, and facet fusion and unilateral screw fixation. It's ASD 2-3, scolio. Is a kypholysis of endoplace, fracture maceration, and this state is not a foraminal stenosis. So I release the rod in this point and screwing the one side, moving the upper and bone graft, the facet joint. So preoperatively, postoperatively CT, and the following 3 months after that, I found some change on the facet. It is not too strong. It's only 3 months, but the facet spony surface is changed. It looks like some kind of fusion. So anyway, the clinical symptom is okay. But the clinical symptom satisfaction in early stage comes from the result of the decompression, not the fusion. So the full decompression, foraminal decompression, is more important than the fusion technique. Only the instrument in the fusion is augmentation to prevent further collapsing of the segment. So in endoscopies, the fusion indication is clinical symptomatic instability rather than the radiographic observational instability. So now, from today, we just try to think as an endoscopist rather than open spine surgeon. Then you can change the word, and you can give a big hope to the senile grandma and grandpa. Thank you. Thank you very much.
Thank you once again for the surgery and for this final lecture on foraminal pathologies. We thank you once again for your presence and for this insightful view of how to treat those foraminal pathologies. So with this, we'll wrap up the 14th edition of our didactic course. I would like to thank all surgeons and for sharing their time and knowledge and that made this wonderful experience possible. And our host, Dr. Gun Choi, for idealizing and leading this course. We hope all of you have the chance to learn and experience about unilateral bipolar endoscopic spine surgery with our experts. Be sure to check more updates on Spine Academy as we'll show some of the some of the parts of this course in our academy. So feel free to enjoy its content back again. I'll leave the word with Dr. Gunchoi.
Thank you, everyone. I'm very exciting. We did a really successful meeting. Initially, there was so many attendee, too much, so the internet was out of order, so we delayed. It's good news, one of the good news. Anyway, otherwise, the quality of our live surgery and the lecture is, I'm sure it was world top. The lecture and live surgery and quality of transmission. And I really thanks all of my staff and my friend and colleague. Thank you very much. Goodbye.